welcome one and all to the Reticon 2020. I think it's first my privilege to invite all my speakers for the day, and most important, I must thank each and every one of them to say yes for a program of this magnitude, purely based around the retina. And I think it's always been a pleasure for us bringing to you guys Reticon, because it's a very, very deep part of Agarwal's inbuilt, innovative technology platform, where we actually believe that retina is where everything starts off for us. Even though it's not the opening batsman, as we call it in cricket, even though they don't hit sixers like a batsman does, they are the bowlers. They're the ones who take the wicket. They're the ones who really save the day for a lot of us in the second set. And we being the one, I would like to say that I'm privileged to have such an esteemed panel to present Reticon 2020, which is for the first time going live and online platform like this. At the onset, also would like to give you some amount of housekeeping slash rules for the day. But first, I hope everybody is fine in their houses in this time of the global pandemic. We sincerely want to thank each and every one of you attendees to be here this Sunday morning, afternoon, evening, depending on wherever you are. A very, very special mention about our sponsors, without which this event was very, very challenging and tough. So thank you very much, all sponsors. Some basic rules. We love interaction with our audience. And to ensure this, we want you to reach out and please post your questions on the reticon.in website. I repeat, post your questions on the reticon.in website. YouTube and Facebook, unfortunately, might take a little longer for us to respond / get the questions to the presenters. So if you want to have questions answered during that session, please post it on the reticon.in website. And pretty much that's about it. I'm handing over the baton to Dr. Atul, who's the organizing secretary for this Reticon and has been for some time now. Thank you very much, everybody. And I hope everybody has a great show today. Atul, all over.
Yeah. Good evening, guys. And now we are going to directly start the Reticon 2020. And I would like to hand over the mic to Dr. Zabeen. She will take the moderatorship of first session. Dr. Zabeen. I think
you're muted. Dr. Zabeen, you're muted.
You're on mute.
Right. Good evening and welcome to the Retina Medical session of Reticon 2020. It's my pleasure to welcome our first speaker, Dr. Ramana Kumar, a private practitioner from Chennai. His topic would be OCT. Welcome, Dr. Ramana.
Sharing the screen now. Can all of you see it? Is my screen seen?
Yes, yes.
Yeah. One second, there's a problem. I can't see my screen. Is my screen seen now?
Yes, screen is seen, but you need to make it full screen. So you probably have to go to that presenter view. Yeah.
Yeah, is it okay now?
Yes, perfectly fine. Just in the meanwhile, I want to introduce the panel. Panel of this first session, the Retina Medical, is Santosh, Dr. Jabin, Padma Preeta, and Dr. Munna Bende. Welcome, panel. We will definitely pounce on your ideas and thoughts during and after this session. Thank you. Dr. Ramana, all yours.
Yeah, okay. Good evening and namaste to everybody from India, from all the international speakers. As usual, it gives me immense pleasure to be part of this meet. Thanks, Atul and Agarwal team. And I'm going to take you through a few pictures of OCT. And I feel it's the most important gadget all of you know today in any retina practice. Whenever we see OCT, I think it's basically we have to broadly classify into three broad classification as to where the pathology is actually starting from, either from within the retina or from the choroidal side or from the vitreoretinal interface, and that straight away gives us an idea as to where the problem is. If you see these three pictures on your left side, you can actually see that the outer RPE and choroidal layers are intact, and the problem is within the retina. Whereas if you see the pictures on the right side, straight away you can see that the neurosensitive retina is perfectly all right, and the problem is under the retina. So this straight away gives us an idea as to where the problem is actually started and narrows our diagnosis. Normal OCT, one needs to be aware of the dark bands and the light bands. All the nerve layers are all bright bands along with the RPE and the limiting membranes, and all the layers of the nuclei are the dark bands. All retinal conditions under the sky have their own characteristic typical OCT picture. We cannot really, it's out of the scope within 5 minutes to cover everything and try to touch upon the important pictures. If not the spectral domain OCT, probably we wouldn't have even known about what is called as a macular traction, an out posterior hyaloid, and a serious macular detachment. And now we know that OCT has given us a new classification for diabetic macular edema. Now, if you see with evolving technology, OCT has given us new terminologies like disorganization of inner retinal structures and hyperreflective spots as well. Now, coming to OCT in vein occlusion and retinal artery occlusion, a small tip here: whenever you see one half of the OCT is normal and one half is edematous, in all likelihood is a BRVO. Whereas in case of a CRVO, you have a diffuse retinal edema involving all layers and kind of extending beyond the macula. Now, if you see, whenever you see this kind of a picture wherein there is edema of the inner retinal layers, straight away you need to be aware of the possibility of an artery occlusion. Both the top and lower pictures on the left side showing a central retinal artery occlusion, which over a period of time there is thinning of the neurosensitive retina. The clue here is normal looking outer layers and edema of the inner layers. Mactal, once again, OCT has revolutionized our thinking about Mactal. Whenever you see you have cystic spaces in the retina with thinning of the retina, please alert yourself to the possibility of what is called as parafoveal telangiectasia or Mactal. Now, OCT has given us a total different classification of Mactal as well. It also shows us whether there's a percent of CNVM in the case of Mactal. Now, coming to conditions which shows cystic spaces in the retina like a Mactal or BRVO or a PFT, you need to understand that whenever there is one half of the retina is involved, it's a BRVO. When you have hyporeflective cavitation and thinning of the retina, it's likely a PFT. In case of a pseudophakic CME, the edema actually starts in the inner nuclear layers and is more confined towards the posterior pole, whereas the CRVO is more diffuse. Now, wherein in case of edema, you'll have associated hard X-rays and which are problems. Now, CSR, right from day one of a CSR, the OCT gives us all information about how the SRF is behaving, the site of leak, presence of PEDs, the pachychoroid and chronicity, so on and so forth. Whenever you have a myopia with unexplained visual loss, please do an OCT. Look for the endless findings that OCT can give, like a foveal schisis, ERM, a myopic CNVM. And sometimes this can be the outer lamellar hole in a myopic foveal schisis can sometimes be confused with the optic pit with the serious detachment of the macula. Interface disorders, OCT has given us a whole new idea, starting from VMA to VMT to a macular hole to a post-surgical maculosis, how it evolves and how it closes. Also about the ERM, the type of lamellar macular holes like ERM associated and degenerative. Coming to dry AMD, today OCT as the CAM consensus has given us a new classification based on involvement of outer retina and RPE. Now, there's a whole lot of appearances which one need to be aware of, like a paint brush appearance in case of RP atrophy, the outer retinal tubulations, and the subretinal hyperreflective material. OCT is still good enough for you to diagnose whether it's a type 1, type 2, or type 3 CNVM. Now, it clearly classifies and explains in detail about the type of PED, presence of SRF, intraretinal fluid, and the presence of RP rip as well. Just because of this web source OCT, today we have a whole new pachychoroid spectrum and identification of all 4 types of pachychoroid and the double layer sign. Coming to inflammatory disorders like weak age, posterior scleritis, and white dot syndromes, it helps us in identifying and following these patients. Whenever you see a bump like this under the retina, please alert yourself to the possibility of a tumor like a choroidal hemangioma or a melanoma and do OCT. Not to last but not the least, with the pandemic around, HCQS toxicity has a very typical picture on the OCT, and So much so that it is spectral domain OCT is part of one of the screening criteria for HCQS toxicity. To summarize, it is the most diagnostic important tool in ophthalmology for diagnosing retinal and choroidal pathologies, and helps in advanced deep visualization as well. Thank you. Not the least, with the pandemic around, HCQS toxicity has a very typical picture on the OCT. And
Guys, can everybody mute themselves, except Dr. Ravana?
Thank you, Dr. Ramana Kumar. That was short and very crisp. We'll go on to FFA and ICG by Dr. Parveen Sen from Shankar Netralaya, Chennai. Dr. Parveen Sen.
Ramana, can you stop sharing your screen so that I can share mine? Yeah, thank you. So, good evening, everybody. So, at the outset, I like to thank Team Reticon for inviting me to this wonderful platform. So, Dr. Ramana has set the ball rolling, and he has very quickly summed up his talk on OCT, which is an extensive topic, in a very short period of time. So I will also try to do the same. So I will straight away probably go to the role and the rationale for doing these invasive investigations like fluorescein angiogram and ICG in the era when so many other non-invasive investigations are available. So just to recapitulate, we know that we have various phases of an angiogram which we need to interpret once we do get these reports with us. The choroidal, the arterial, AV phase, the late phase, and the recirculation time. The importance of understanding these things is that in cilioretinal artery is probably the only exception where you have the artery filling during the choroidal phase. And this is the timeline in which you will see these different phases. The importance of this timeline is that based on this timeline, we calculate a very important parameter, which is the arm to retina time. And this can help us diagnose an important condition, which is the vein occlusions, in which cases the arm to retina time can be extremely delayed. And this is a very important finding, which is sometimes not available on OCT at all. Another condition where FFA may still score over OCTA is the field of view, which in Octa is at this point of time still restricted at 45 degrees, while FFA can easily show you up to 200 degrees. And this is of paramount importance when you're looking for peripheral neovascularization or vascular filling defects, especially when vascular filling defects present at posterior pole. Octa can pick it up, but if this is the inverse situation, as seen here, that the posterior pole is near normal and the periphery is full of vascular non-perfusion areas, you will miss the diagnosis. Most of the pediatric vascular disorders need an angiogram, and we still don't have enough facility on the Octa to diagnose conditions like FEVR and also treat them. Here you can see the fundus photograph post-treatment shows a well-lasered retina, but when you see the FFA, you realize that this area is probably untreated and needs more treatment. Other eye examinations, especially in asymmetric diseases like FEVR, the other eye may look normal until unless you do an FFA and realize that the other eye also needs treatment. Same for Roper. And when you want to treat the microaneurysms or the leaking macroaneurysms or arterial malformations like Coats disease, or even in DME, if you plan to do laser photocoagulation, FFA showing you the increased number of microaneurysms is useful, as well as FAZ, which is well marked, is a good landmark while doing focal laser for DME. While treating CSE, all of us would definitely want to have an FFA at hand to look at the points of leak. And in multifocal CSE, it's absolutely paramount. All these focal points of leakage cannot be picked up by any other investigation. Asteroid hylosis, we know on fundus examination, a lot of details are not seen. But if you do an FFA, you don't see the difference between the two eyes, one with the asteroid and one without the asteroid. Octa recent publications have shown, and we have also seen that it does show details in spite of asteroid hylosis, but because of these media opacities, you could have artifacts which could hamper your quality of image. Myopic CNVM very well picked up on Octa, but the activity, you still, some of us may prefer an FFA because OCT may not show you subretinal fluid in either case. So coming to ICG, the value that ICG has above FFA is largely because of its pharmacodynamic property, that it is 98% protein bound vis-a-vis FFA fluorescein, which is about 60 to 80% bound, and it leaks through the fenestrated choriocapillaries. And the absorption and emission spectrum of ICG is such that it goes through the RP and the choroid very well. And we have the phases of ICGA in the early phase, which is within the first 1 minute, the mid phase, which is 1 to 15 minutes, and the late phase, which is 15 to 30 minutes. Again, these phases are very important because different diseases could fluoresce at different phases of time and help us in diagnosis. You could very much interpret ICG just like FFA as hypo and hyperfluorescence, but it is slightly more complex because it is based on the choroidal circulation, which has a wide spectrum of normal patterns, especially when you see the normal choroidal blood circulation. You may have a natural vascular filling defects, which is called the watershed zone between the medial and the temporal PCA, as is seen here. So if you do not know what is normal, you may consider as if this is a vascular filling defect which is appearing. Largely, ICGA is indicated now in the retinal disorders that I'm limiting myself to, is indicated in conditions like CNV, where an occult CNV can be seen either as a hotspot or as a plaque, and especially in type 3 CNV, where you can see it is seen in a patient with the RAP. It can help us pick up the infusing arteriole or the feeder vessel, and RAP is often associated with pigment epithelial detachment. And in presence of a serious PED, there can be so much of pooling on FFA that you will the vascularization spot. Vis-a-vis ICG, because there is no pooling and staining on the pigment epithelial detachment, the vascular network appears as a hot spot and is seen in the mid phase of ICG because it fills with the arterial circulation, retinal circulation. PCV, we cannot diagnose as of now, at least without ICGA, though the newer swept source OCTA is improving the diagnostic features on OCT itself. There are two components, both of them are very beautifully seen on an ICG. And it is again very important to look at which phase you are seeing. First 1 minute itself will show you the BVN. So you must the photographer must be good enough to know that it's the first 1 minute is very vital. You can pick up the BVN and the polyps, and you can characterize them further in the first 6 minutes by the surrounding hypofluorescent halo, which usually represents an active polyp. The late phase of ICG, about 10 minutes later, you could pick up late geographical hyperfluorescence, which is usually signifies an underlying unhealthy RPE. For treatment, especially if you're planning a PDT, you have to have an ICG. Same way for CSC, if you're doing a PDT, you need an ICG to look at the choroidal hyperpermeability. Though you can diagnose the pachyvessels even on an NFAS OCT or an OCTA, but to know whether they are pathological and hyperfluorescent, you would need an ICG. Same for peripapillary pachychoroid syndrome. You can see the pachyvessels are more on the nasal side of the fovea than on temporal, and this helps in the diagnosis. So the limitation of these two techniques is that they are invasive, but we have over so many, almost half a century of experience, that even though they're invasive, they're relatively safe, they are useful tools, and still a knowledge of these can help you uh, make your diagnosis and treat very effectively, and it is not yet time to completely write them off. Thank you for your hearing, and that's all for me today.
Thank you, Dr. Sen. Our next speaker is Dr. Vasumati Vedantam of Radha Trinetralaya, Chennai, on OCT angiography. Welcome, Dr. Vasumati.
Thank you, Jabin. And I would like to share my screen now. Is it seen? Is my screen seen? Is my screen seen?
Yes, yes,
Yes,
but
yes, yes.
it's a little small. You'll have to. It's part of the screen only.
Slideshow.
Yes, that's brilliant.
All right. Yeah. First of all, thank you and congratulations to Dr. Agarwal's family for Reticon 2020. And thank you, Atul and Ashwin, for the opportunity. So I would be talking on OCT angiography, which is a game changer in the field of medical retina. And coming to the basic principles of OCTA, as it is referred to, it is in fact a better modality of imaging. In fact, it's a very good combination of ICG, fluorescent angiography, and gives much more valuable information. And this is the OCTA picture that you can see of the CNVM, which is as good and even better than ICG and FFA pictures. And all the four capillary plexuses are beautifully imaged: the superficial, the intermediate capillary plexus, and the deep capillary plexus, as well as the choriocapillaris layer. And the mechanism is quite simple. It's sequential OCTP scans performed repetitively at the same area. So the motion of the scattering particles, like the red blood cells, are captured, which give valuable information, volumetric information about the blood flow of both the retinal and the choroidal circulation. Of course, the most important bugbear are the several artifacts, which I will skip for want of time. And OCTA is possible with the newer spectral domain OCT systems as well as the web source OCT systems. And it has several applications, and I will deal with each one of them one by one very quickly. First is diabetic retinopathy. And in fact, OCTA has been suggested to be a screening tool because early microcirculatory disturbances in diabetic eyes, even without diabetic retinopathy, has been demonstrated by OCTA by an enlargement of the FAZ. And it also, of course, demonstrates the classical diabetic retinopathy findings like microaneurysms, retinal neovascularization, irmas, etc. And of course, it has certain minuses when compared to fluorescent angiography in diabetic retinopathy because there's no information on the blood retinal barrier status. You can't detect a hot disk. And the peripheral CMP areas and the peripheral NBEs as of now are not discernible because we don't have a very good wide field OCTA, which is freely available now. However, the most important is you can distinguish between the superficial and the deep capillary plexuses abnormalities. And also, it is better at detecting non-perfusion because you see the fluorescent angiography picture here. There's a lot of leakage which confounds the picture, but the OCTA here clearly shows the extent of the capillary non-perfusion areas straddling the enlarged FAZ. So there is no confounding leakage. And also, it gives much beautifully all the microaneurysms and the CMP areas demonstrated by OCTA here when compared to the fuzzy fluorescent angiogram to the left. And as I already mentioned, both the superficial and the deep capillary plexus abnormalities are highlighted by OCTA in contrast to FFA. And also, we can make out the areas of the capillary non-perfusion. And the most important tool in OCTA is actually angioanalytics, wherein you can measure the non-flow areas, which give us valuable information. And in fact, it has been suggested by a beautiful paper by Lee et al. That whenever there are more microaneurysms in the deep capillary plexus, as well as more loss of capillary density in the deep capillary plexus, it's a sign that probably that patient is not going to do so well following anti-VEGF injections as seen in this case. And also, it is a marker. The FAZ enlargement has been suggested to be a marker for peripheral ischemia, which is quite common in type 1 diabetics. So whenever we see an enlarged FAZ in a young juvenile diabetic, we should be able to predict that the patient has significant peripheral ischemia as well. And the neovascularization on the disc is also beautifully seen. You have either these exuberant vessels or these fibrotic vessels, and you can see the involution of the NVD following anti-VEGF therapy, as well as parafoveal neovascularization elsewhere can also be picked up. This is the FFA picture, and this is the angio-OCT picture by OCTA. So OCTA is quite useful in diabetic retinopathy, and we have several advances also to look forward to. Coming to the second most important application, which is the CNVM, all the three types of CNVM, be it type 1, sub-RP CNVM, this is the type 2 neovascular AMD CNVM, as well as the type 3 RAP, which is so beautifully imaged here, can be made out by Opta. And in certain diagnostic dilemmas wherein there is just a mass and the fluorescent angiography is absolutely unrevealing, the Opta is able to beautifully pick up the CNVM. So it has helped us on many an occasion, and this is the parafoveolar CNVM, which is also picked up by Opta in one of our patients. And again, angioanalytics plays a crucial role in the way we manage the CNVM patients. This is, you can measure the flow area of the CNVM, and this is the video, and you can see that slowly, this is the extent of the CNVM which is measured prior to the anti-VEGF injection. And after the first anti-VEGF injection, you can see that the CNVM size is very much reduced. So it's a very good tool to explain to the patients also that the treatment is actually working. And you can also measure the CNVM flow area. This is the pre-injection flow area, and this is the post-injection flow area. So you can see that the anti-VEGF is actually very efficacious in this patient. Prior to the anti-VEGF injection,
Madam, can you please
OCT
wrap
has
up, please?
superseded FFA in the management of CNVMs. And of course, there are certain limitations which cataracts and all you can't image well. And of course, in retinal vein occlusion, both neovascularization, CME are enmeshed well, and in parafoveal telangiectasia, OCTA is very good. And also in CSCR, and it helps us to identify the second membrane when we are suspecting an occult neovascular membrane. And these are several new OCTAs which we are looking forward to. So thank you so much for the opportunity, and all the very best for the next speakers. Thank you. And of course, in retinal vein occlusion, both neovascularization, CME are enmeshed well, and in parafoveal telangiectasia, OCTA is very good. And also in CSCR, and
Okay, our next
helps us
speaker
to
is
identify the
Dr.
second
Pukhraj
membrane
Rishi on
when we are
multimodal treatment of
suspecting
retinoblastoma.
neovascular membrane. And these are several new OCTAs which we are looking forward to. So thank you so much for the opportunity, and all the very best for the next speakers. Thank you. And of course, in retinal vein occlusion, both neovascularization, CME,
Dr.
are
Pukhraj
enmeshed well,
Rishi.
and in parafoveal telangiectasia, OCTA is very good. And also in CSCR, and
Okay, our next
helps us
speaker
to
is
identify the
Dr.
second
Pukhraj Rishi
membrane
on
when we
multimodal.
are
Okay, we'll
suspecting
move to Dr.
neovascular
Munna
membrane.
Mende,
And these are several
diabetic
Can you
new
hear
macular
me?
edema.
OCTAs
Okay,
which we
okay.
are looking
Pukhraj Rishi,
forward
sir,
to.
is
So thank you so
Sorry,
much for the opportunity,
and
and all the very best for the
if you can see
next
my
speakers.
screen, please let
And
me
of course,
know.
in retinal vein
yeah.
occlusion, both neovascularization, CME,
Dr.
are enmeshed
Pukhraj
well,
Rishi.
and in parafoveal telangiectasia, OCTA is very good. And
Right.
also in CSCR, and
Okay, our
Good
next
evening,
speaker is
everyone.
We are
Dr.
not able
Pukhraj
to
Rishi on
see your
multimodal.
share
Okay,
screen,
we'll
sir,
move
yet.
to
Can
Dr.
you share your screen
Munna
with us?
Mende,
It's not.
diabetic
Can you
macular
hear
edema.
me?
Okay, okay. Pukhraj Rishi,
Uh,
sir, is
so thank you so
Sorry,
much for the opportunity,
and
and all the very best for the
if you
Yep,
can
next
see
now
my
speakers.
it's
screen,
opening
okay.
up.
please let me know.
Thank you.
Thank
Yeah,
you.
yeah.
Yeah. Good evening, everyone.
Dr. Pukhraj Rishi.
Um, I'll be so at the onset. I like to thank Team
Okay, our
Reticon
next
for
speaker is
involving me in
We are
this
not able to
event.
see your share
okay,
screen,
we'll
sir, yet.
move to
I'll be
Dr.
speaking
Can you
on
share your screen
Munna
multimodal
with us?
Mende,
management
It's
of
not.
diabetic
retinoblastoma
macular edema.
through some
Okay,
case
okay.
examples.
Pukhraj Rishi, sir, is
So, as we know, managing retinoblastoma is
Yep,
as much
now
an
it's
art
opening up.
as it is a
Thank
science.
you.
yeah, yeah.
So, good evening, everyone.
Dr. Pukhraj Rishi.
I'll be so at the onset. I like to thank Team
So
Reticon
this is not
for
an
involving me
unusual
in
We are
this
not able to
event
see your
for
share screen, sir.
especially for I'll be the speaking on
Thank
ocular
you.
oncologists practicing in the
Diabetic
developing
macular
world
edema.
who are familiar with orbital
Okay.
retinoblastom. The upper panel shows a child with severe
Yep,
proptosis
now it's
and
opening up.
is also
Thank you.
Yeah,
as also seen on MRI
Dr. Pukhraj
uh,
Rishi.
involving the orbit. So this child is the approach here would be treating this child with neoadjuvant chemotherapy, and once the tumor is reduced, the eye becomes classical, making it more amenable to a safer enucleation as seen in the lower panel. And so the child goes on to complete 12 cycles of chemotherapy per protocol and followed by radiation therapy. A metastatic workup is inherent in the protocols for managing this. So case 2 is that of an 8-year-old girl who was referred to the diagnosis of recurrent anterior uveitis of 2 months duration. Her past medical history was significant for bilateral retinoblastoma detected at 3 months of age, and her right eye was enucleated at 1 year of age elsewhere. However, she did have an orbital recurrence 5 years later, for which she was treated with chemotherapy and radiation again elsewhere. So this was the MRI imaging of when she presented to us. Attention is drawn to the anophthalmic socket in the left eye and in the right eye, and uh, chorioretinal thickening in the infranasal quadrant. This is in the eye, and this is how she presented. There are creamy white, globular lesions floating in the AC and behind the iris of multiple shapes. The fundus showed primary retinoblastoma with vitreous seeds. The view was hazy, however, we could make out the primary source of the anterior chamber seeds. So the, and of course the UBM helps us image the unseen seeds in the pars plicata pars plana region. This child had reasonably good vision. Fortunately, IOP was not very high, and metastatic workup did not reveal any malignant cells. So there are several approaches which one can employ as a single or a combined therapy. And this child did undergo intraarterial chemotherapy with a favorable response. And these are the sequential images from the first, second, and the third intraarterial chemotherapy. So this could give you a false sense of a treatment endpoint here. However, with a UBM imaging, you can find those seeds hiding behind the iris in the ciliary body area, especially in the canal of Hanover, where the zonules can harbor these seeds, and which could lead to a possible recurrence in the future. So a physical inspection of the injection site to look for extraocular extravasation of the potentially viable tumor cells and the UBM can make sure that you have reached a treatment endpoint. This panel shows paired images of interior and posterior segments over time, and here you can appreciate how the retinoblastoma cells have regressed. So the take home from this case is always treat the primary tumor first, and just anterior chamber injections will prove to be ineffective. Bicameral injections in the same treatment session is recommended, and we must employ safety techniques. This is just not like any other intravitreal or intracameral injection. You must monitor with UBM to look for unseen vitreous seeds. So case 3 is a 5-year-old male child who presented with a bilateral group D disease. This is the right eye. Look at the tumor abutting the disc. And this is the left eye with a disc overhang. The tumor is breaking through to the vitreous cavity. The right eye, after 4 cycles of intravenous chemotherapy, that left eye completely regressed following 4 cycles of intravenous. So we switched to intraarterial chemotherapy only for the right eye. However, down the line, in the marked area, there's a tumor recurrence for which the child underwent intravitreal methotrexate and with good response. However, 6 months later, there was another recurrence, which was then treated with a plaque radiation, and again with a favorable response. So there is a long-term commitment to these patients, and you have to be very careful because there's a lack of contrast. You can see a recurrence which is white cream over a creamy white underlying tumor. So you have to be really very careful in detecting this really early on. So later, a few months later, the child developed diffuse vitreous hemorrhage. So this is a 6-6 seeing eye, and it's very difficult to convince the parents at this stage to get rid of the eye. So also bearing in mind that there is a severe ischemia from the preceding treatments like intraarterial chemotherapy, intravitreal chemotherapy. So we did a less than half dose intravitreal ranibizumab with peripheral cryo, 2 sessions, and the child responded well. And we did a fluorescein angiogram just to make sure that there was no active retinoblastoma. And this slide shows a treatment summary of what all this child underwent, especially in the right eye. And fortunately, he responded well. And there was We followed it up with a peripheral scatter laser photocoagulation just to reduce the ischemia. The logic based on how we treat our PDRs. So for now, till March 2019, the child is doing really well. The vitreous hemorrhage is gone. You can make out the telangiectatic vessels on the tumor surface, but they're just sitting there. And we've reduced the hypoxic load by doing the peripheral PRP. So in conclusion, retinoblastoma can present with varied clinical presentations and also a varied clinical picture during the ongoing treatment. And there are several aspects that need to be considered to chart the right approach, meaning the age, laterality, visual potential, the staging of the disease, and one should employ a multimodal approach which can help achieve optimized outcomes. Thank you for your attention.
Thank you, Dr. Rishi. Our next speaker will be Dr. Muna Bhende on the current management of diabetic macular edema. Dr. Bhende.
Can you hear me now?
Yes, we can hear you, ma'am.
Yeah, good evening. I'm just going to go through briefly the current concepts and management of macular edema. Sorry, my slides are not moving. Okay. It's most important to know your patient first and in the eye. Is the patient a diabetic or not detected yet? What medications is your patient on? Has there been a recent change in medications? What is the other systemic relevant history that could influence your treatment? And what are the drugs the patient is taking? And can that influence either the clinical picture or the treatment? Has there been any recent ocular surgery? What was the vision before diabetic retinopathy? Any details of previous treatment, especially with relevance to intravitreal injections, the drug use, the protocol, the subjective response, and the compliance of treatment? This is a 66-year-old lady who was hypertensive, hypothyroid, dyslipidemic, who came with features of background diabetic retinopathy and central involving macular edema in the left eye. She did not reveal any history of diabetes. A physician who confirmed diabetes treated her for a month, and then the condition remained status quo. She received 2 monthly injections of eccentrics, but vision did not improve beyond 6/18 and 8, in spite of a good anatomical response. And then when we repeatedly questioned her, we found that vision in the left eye was always poor, and we found that she had a microtropia. So these are things that you need to look out when you're looking at treatment response. This another gentleman, a type 2 diabetic diabetes on insulin, was referred for anti-VEGF injections for diabetic macular edema. The OCT showed bilateral neurosensory detachments, which raised the red flag. Hemogram was abnormal, so we referred him to the oncologist, found to have multiple myeloma. We deferred treatment. 6 months later, the neurosensory detachment had subsided, and then he could just have focal laser to the extrafoveal microaneurysms. So in case of systemic comorbidities, points of concern that most of us have. In case of a recent vascular event, preferably avoid anti-VEGF injections for 3 months. If a patient is pregnant, try and avoid anti-VEGF injections totally. Look at the option of steroids or laser. If not possible, wait till the 3rd trimester. In the presence of active infection, wait to inject. Consider laser if the treatment is important. And always look at the foot in addition to the eye, because diabetic foot is one of the most commonly missed conditions. In case of an altered lipid profile, concurrent treatment for DME is acceptable, but a good control gives you a better treatment outcome. And in refractory DME, always look for obstructive sleep apnea or a patient who is on the glitazone. More recently, we've known that renal parameters can go haywire in a patient of multiple anti-VEGF injections, so this is something you need to note. Evidence for anti-VEGFs is strong. The sustained visual gains for a long time with reducing need for injections over the subsequent years. There's a concurrent reduction in severity of diabetic retinopathy as well. However, it's important to have monthly follow-ups at least for the first year. Now, if you have a patient with good vision, There is an option proven by Protocol B to observe the patient or treat and the responses are the same. However, involving macular edema with lower vision, you need to treat the patient. If compliance is likely, treat with laser. If compliance is good, then you treat with anti-VEGF or steroids. Which one to choose? Either is fine, but aflibercept has shown a better response in thicker macula and poor vision. And the treatment protocols are many. Most of us would tend to start with 3 monthly injections, and this response usually predicts the final response. So it's important to know these three. Coming to the role of steroids, primary use of steroids is rare, usually reserved for patients who are unfit or unwilling for monthly anti-VEGF injections, can be used in pseudophakics or patients undergoing cataract surgery, usually used for recalcitrant DME. And when do you switch? Usually after 5 to 6 monthly injections. Combination therapy can reduce the burden of injections, give you a better anatomical outcome, but has not proven to have visual benefit. And this is a patient who had an initial good response to Avastin. You see, as he progresses, he loses the response. With one injection of Ozurdex, the macula got flat and remained so almost up till 11 months. And this is a gentleman with bilateral DME, underwent laser intravitreal injections. 9 months down the line, we see vitromacular traction in the left eye and extrafoveal edema in the right eye. 2 years post vitrectomy in the left eye, you see he has a flat macula and 6/6 vision. When do you stop? Generally, we inject monthly until no further reduction of macular edema is present. Then you may consider adding focal laser to these patients, and you can potentially follow patients with mild residual edema over time without necessarily giving injections. To optimize DME therapy, we should know it's not AMD, that there are other options other than injections. Know your patient well first. Consider whether to treat or observe. Choose your treatment regimen appropriate for the milieu. Know the endpoint of treatment, but know the importance, and your patient should know the need to follow up lifelong. Define resistance, know how to handle it, the selective role of vitrectomy. Most important, you have patient compliance and diabetes control. Thank you very much for your patient listening.
Thank you, Dr. Mona. That was brilliant as usual. Our next speaker is Dr. Avinash Patenge from LVP on Pearls and uveitis. Welcome, Dr. Avinash.
Hi, Devin. So probably at the outset, I would like to thank Ashwin and Atul for giving this opportunity again. Now, today I'm not going to talk about pearls, but I'm going to talk about situations how you can bridge the pearls into as a clinical reasoning. So I'm going to discuss two scenarios today. So the first one is, our country being an endemic country. So, and we all know that there is always this doubt about tuberculosis or not, right? Whenever you're dealing with uveitis. So, I would say when there is a doubt whether there is tuberculosis or not, though we have set down a late criteria of what would be like in terms of broad anterior synechiae, you have the mutton fat keratic presperates, then peripheral anterior stented synechiae and all the stuff. So, but for me, what we recently published is majority of the times when we have to make that clear differentiation or make that clinical diagnosis of possible tuberculosis, it usually comes from the posterior segment and not from the anterior segment. And these are the three important clinical signs by which one can make a possible diagnosis in an endemic country like ours. Number one is a subvascular pigmentation. Number two is focal kinking of vessels. And number three is reactivation within the scalp. Now, let us look into what the subvascular hyperpigmentation is. So, if you look at this photograph, this is a patient who presented with a choroiditis patch, and he also had a neurosensory detachment adjacent to it, and there's a hyperpigmented scar superior temple to this choroiditis lesion. So, this patient was diagnosed to have tuberculous choroiditis, and what I want you to lay your mind or focus on is that choroiditis lesion. After ATT, you can see that it just disappears and it reduces to 1/10 of the actual size. And under this vessel, you can see the subvascular hyperpigmentation. This is how a choroidal granuloma or choroiditis patch following tuberculosis resolves. And when you keep this picture in mind, anytime when you get to see a lesion like a vasculitis or there's any other inflammatory condition, you look out for the subvascular pigmentation in endemic country like this. Now, this is a patient who presented with vasculitis, and in the other eye had a subvascular pigmentation. Something like this would help us to make a sort of pave a path for us to understand there could be a possible tuberculosis-like etiology. So that's the number one in terms of subvascular pigmentation, first point. The second is reactivation within the scar. Also think of tuberculosis. Now, if you see this clover-like leaf-like lesion, right? You can see in the periphery, you can see the scar, and in the center, there is an activity which is there. So this is what I meant when there is an activity within the center of the scar. It usually signifies a possibility of tuberculosis. And when someone talks about reactivation, the mind automatically takes us to toxoplasmosis, which is the commonest infectious posterior uveitis. But the point here, which I want to make and emphasize, is in toxoplasmosis, reactivation happens at the edge of the scar, but in tuberculosis, the activation happens in the center. That's the kind of basic difference between toxoplasmosis and tuberculosis. And if we look into the basic signs, the photograph of a granuloma, which is there in the right, compared to the lesion of what we were discussing now, which is on my left, you can see that in the center is where there is a necrosis, or you have the TB-laden bacilli in macrophages, and that's what is represented here. As and when you look at the lesion in the center, there is more of necrosis, and that very much resembles the pathology of the granuloma and tuberculosis in the lungs. So in the eye, we get an opportunity to see it live, and that's the best part of it. When you see it, the diagnosis is bang on. And second is about kinking of retinal vessels. It's so obvious. I will show you an example of how you can make this diagnosis. So I mentioned about subvascular pigmentation, activation within a scar, and kinking of retinal vessel. Now, this is a patient who has come with decrease in vision. The patient has a retinal vasculitis and a sclerosed vessel in the center. And what could be the possible etiology in this? And there is a skip vasculitis also we can see adjacent to it. So if you look into this, usually we will be perplexed. What could be the possible? It cannot be toxo. It can be tuberculosis. It could be sarcoidosis, or it is be fungus. So these are various things which keep coming in our mind. But if you look in the superior temple, all the three signs which are important to make a diagnosis of tuberculosis clinically exist in this patient. So there is subvascular pigmentation here. Adjacent to that, kinking of the vessels. And third is you have the activation within the scar. So if you use the power of logical reasoning here, the subvascular pigmentation plus kinking of the vessels plus activity within the scar, the diagnosis becomes pretty straightforward that clinically for us to make a diagnosis of tuberculosis. So that was the first scenario which I would like to explain, just to make us a little bit comfortable when you get to see another patient with tuberculosis inside the eye, how we can approach and make the possible clinical diagnosis based on these three clinical signs. The next scenario, which usually most of us would encounter, is whether the lesion what we are seeing inside the eye is infectious or not, because we know that 90% of uveitis cases are non-infectious and 10% are infectious. So those 10% of infectious cases have a different way of treatment. You cannot treat them with steroids. It is going to worsen. Whereas the rest of them you treat with steroids, 90% of the time you would be right. But what would be the clinical sign to suggest if this lesion is infectious or not? And more so, if you look at this lesion which is there, it is so close to the fovea and to the optic nerve head. And if you don't make the diagnosis right and start the patient on steroids, it is going to hit either the disc or fovea very badly, causing a permanent decrease in vision. So let me share with you one clinical observation, which if you look at it and make it, then the diagnosis becomes straightforward. Look for Caerelis vasculitis. If you look for Caerelis vasculitis, as you can see here, over the lesion, you can see the vessels, and over in the vessel, you are able to see the intravascular deposits. The moment you see this intravascular deposits, then it suggests a possible infectious etiology in this patient with unifocal choroiditis. And when you see a unifocal choroiditis, the most two common diagnoses one can make in the clinic in our setting is either it's tuberculosis or sarcoidosis. And when you have the infectious in mind, you set aside its sarcoidosis and start treating towards tuberculosis. And that's what happened in this particular patient. You can see this unifocal choroiditis with Caerelis started on ATT, and then it resolved beautifully with subvascular pigmentation. And another patient, similar unifocal choroiditis between the disc and the fovea, and there's no Caerelis vasculitis. This patient had sarcoidosis, started on half a milligram per kg body weight steroids, and it just melts and disappears. So these are the two different scenarios which I thought I would like to share in this 5 minutes so that we would be able to take back into our clinical practice. And thank you very much.
Thank you, Dr. Avinash. That was brilliant as usual. Let me welcome our next speaker, Dr. Dedullah Chakraborty. His topic is the enigma of similarity. Does RCT translate into real-world practice? Dr. Chakraborty.
Thank you, Dr. Jabin, and thanks, Dr. Ashwin and Atul. I'd like to share my screen. So, I'll be speaking on the enigma of similarity. Does randomized control trials translate into real-world practice? So many of our neovascular AMD patients and DME patients until 2006 had progressive vision loss only to look forward to, and the breakthrough essentially came around 2006 with the advent of ranibizumab, which was approved for use in neovascular AMD. And subsequently, a lot of patients have benefited from ranibizumab as also the other anti-VEGF agents. Now, we've compared various anti-VEGFs in neovascular AMD in the real world, and probably the largest data sets come from the IRIS registry, where 3 anti-VEGF agents were compared head-to-head over 1 year in the US practice. And a pretty much similar number of injections at the end of 1 year, and similar visual acuity results for ranibizumab and aflibercept, with bevacizumab coming out close second. But what about comparing with biosimilars? Well, little data on the public domain. We have the REANX study, which is retrospective multi-center observational study on wet AMD, but it had a duration of less than 3 months, and the endpoint was the percentage of patients with loss of less than 15 letters and 100 patients only. So we did the study across 15 centers of Dishai hospitals. This is innovator ranibizumab versus biosimilar ranibizumab, non-randomized, retrospective, open-label, multi-center phase 4 study of 903 eyes here, visual impairment due to wet AMD, and we had 2 groups, the innovator group and the biosimilar group, with 726 eyes and 177 eyes. So of course, these were treatment-naive patients. At least 6 months of follow-up was necessary. No switching over was allowed, and any other retinal disease or surgery, patients were excluded. Besides the primary endpoint of change in best-corrected visual acuity between baseline and final follow-up, the secondary endpoint we looked at was number of intravitreal injections that the patient received. And moving on to the results, the innovator ranibizumab group with visual acuity 636 or better, that is 0.75 on the logMAR scales, and I will convert it to logMAR, of course. The patients improved by 0.201 logMAR units with the innovator, and with the biosimilar, they improved by 0.078 logMAR units. So this difference was statistically in favor of the innovator molecule. And if you look at patients who had less than 636 vision, the innovator molecule actually had 0.304 logMAR units of improvement. The biosimilar group had 0.133 logMAR units of improvement. Well, better than the other, patients with more than 636 vision. But here also there was a difference between the two. So patients who improved by 3 or more lines, 48% for the innovator and 29% for the biosimilar. Adherence to treatment for more than 6 months, 23% for the innovator and 6.8% for the biosimilar. So a 3-fold difference here. And if you look at the mean number of injections, remember this is neovascular AMD in the real world, 2.1 injections for the innovator and 1.56 injections. That was the mean for the biosimilar. What about patients who took more than 3 injections? Well, 29% for the innovator and 16% for the biosimilar. So in a nutshell, improvement of visual acuity in the Indian context may be slightly more than what we've seen in the West, and drug cost may not be the only factor for compliance. Moving on to the DME part of the study, similar study, non-randomized, retrospective, open-label, multi-center phase 4 study of 1623 eyes, the innovator group having 1159 eyes, and the biosimilar group having 464 eyes. And of course, these were treatment-naive patients with center-involving DME, no switching allowed, and any other retinal disease or surgery were excluded. So improvement in patients who had 636 or better vision was 0.201 logMAR units, and with the innovator molecule, and with the biosimilar, it was 0.137 logMAR units of improvement. So a difference here in favor of the innovator. And regarding improvement with patients with lesser vision, less than 636, well, it was slightly better than the previous group. It was 0.299 with the innovator and 0.191 with the biosimilar. So if you look at improvement by 1 or more lines, innovator, 70% of the patients improved, and in biosimilar, with the biosimilar, 54% improved. So if you look at adherence to treatment for more than 6 months, it was 13% for the innovator group, and for the biosimilar group, it was 6%. So a twofold difference was there here. And the mean number of injections, this is of course DME, 1.63 for the innovator and 1.34 for the biosimilar molecule. A proportion of patients who received 3 or more injections here in DME, 15% for the innovator and 7% for the biosimilar. So the limitations of our study, due to pre-specified criteria, data from only a subset of eyes could be included. Our attrition rates were similar as compared to other RWE studies, and the visual acuity data was recorded as Snellens and then transferred to Logmer for the analysis part of it. And this was mostly a PRN regimen that was used for both AMD and DME. So in a nutshell, visual acuity improvement is significantly better with the innovator as compared to the biosimilar for AMD and DME in our study. And patients on innovator ranibizumab have 2 times significantly better adherence as compared to the biosimilar. Thank you for your kind attention.
Thank you, Dr. Chakraborty. That concludes the session. I thank all our eminent speakers for making use of every single minute of the 5 minutes allotted. Now we'll go on to our next session.
Now, for the next session, the panelists are Dr. Seenu Hariprasad, Dr. Palnivel, Dr. Rekha, and Dr. Mohan Rajan sir. And Dr. Palnivel sir,
yes, Atul.
Take over as a moderator.
Yeah.
So every single minute of the 5 minutes allotted.
We'll move on to the next session, Retina Part Puri. I request all the speakers kindly.
For the next session, the panelists are Dr. Seenu Hariprasad, Dr. Palnivel, Dr. Rekha, and Dr. Mohan Rajan sir. And Dr. Palnivel sir?
Yes, Atul. We'll move on to the next session. Yeah. I request all the speakers kindly stick to the 5 minutes. So we'll start with Dr. Kasinathan from Clarity Eye Hospital, Chennai. Nucleus drops, holistic approach. Yes, Atul. We'll move on to the next session. Yeah. I request all the speakers kindly stick to the 5 minutes. So we'll start with Dr. Kasinathan from Clarity Eye Hospital, Chennai.
The slide visible?
Holistic approach.
Yeah, it is visible. Yeah.
Yes.
Is it visible, sir? Yeah. At the outset, I would like to thank the team Reticon. I would call this meeting as a T20 of Retina because everything is in a short format. So managing the nucleus drop, I would say this is the best marketing tool for a VR surgeon for his better referrals. And that too, if you do free of cost, you get your referrals are very much assured. And why I call this as a holistic approach, unlike the other VR management, here we have to deal with the patient, not only with the patient and attenders, but also with your anterior segment colleagues, because they are hard pressed for you to do the case as early as possible. That's why I call this as a holistic approach, because we have to deal various people. The bitter truths about management of nucleus drop is it's never an emergency. So don't get compelled by your colleague for doing the surgery at the earliest when the situation is not great enough. And first thing and foremost thing is don't blame your colleagues. And very important is patient counseling and reassurances of your patient. And a good strut lamp examination is very important to choose the choice of your IOL. Look for the wound integrity. Also look for the corneal edema. If the edema is there, you have to wait for some time for the edema to clear. And if there is intraocular pressure is high, you have to manage the pressure. And if you see the remnants of anterior capsular rim, always you can place a SF-IOL or a sulcus IOL. And also look for the vitreous in the wound and anterior chamber. And also a good indirect ophthalmoscopy is equally important because that will make you to decide whether you need a frag or not, and if you need a laser or something or a tamponade, because all these things will help you to counsel and prepare the patient before the surgery. And the various predisposing factors, I'm not getting into those things, but the most important thing, never blame the surgeon. And the timing of the vitrectomy, perioperative, if the facility is available, that happens only in institutes, or if it's in a private practice, you can wait for 1 to 2 weeks based on the corneal intraocular pressure. And early vitrectomy is indicated if there is a vitreous hemorrhage or retinal break or retinal detachment. And vitrectomy, always try to look for capsular remnants. Anterior vitrectomy should be very meticulous because you should not damage the pre-existing capsule. And intraoperative mydriasis can be achieved by adrenaline or irisux. And don't damage the remnants of anterior capsule, whatever is left. PVD induction is always variable, depends on the mobility of nucleus and fragments. If the nucleus and the fragments are mobile, you don't need to. If it's a fragment, most probably will induce a PVD induction and can be done pre or post fragmentation, so long the nucleus is mobile. And sometimes I think this acts like a posterior cushion, so that if the hard nucleus falls on the retina, the damage to the retina is limited. And depending on the size of the fragment, either a cutter or a fragmentome can be used, depends on the size of the remnant nucleus. And the fragmentation setting is done only after adequate vitrectomy, only when the nucleus or the nucleus fragments are mobile. It's always done in the mid-vitreous cavity. For the bigger piece, you need to have high vacuum. As the pieces get smaller, the most important key here is you have to reduce the power to prevent the shattering of the remnant pieces. And you have to use saline on the fragmentation side, because this induces a lot of heat on the sclerotomy if you're using a 20 gauge frag. And in case 23 frag are reason nowadays available, in that case, you have to remove the cannula, because metal to metal contact can cause the breakage of the frag tip. And if it's a hard black cataract, it's better to remove as an end mask through the anterior route. And role of PFCL is to protect the macula from hard landing of the hard nucleus. And if there is an associated retinal detachment, the PFCL can keep the retina back in place. And choice of eyeball depends on the capsular remnants and the type of the wound. And the most important thing is you have to educate your colleague. Experience is not, there is no complication. Experience means knowing to manage how your complication. And what you need to tell your colleague is make a clean and neat wound. Ensure there is a round pupil at the end of the surgery. And if the surgery is confident, your IOL can be placed, so that your headache of placing an IOL is taken away. You can remove the nucleus, and they can do a good anterior IVT assisted or Kinecort assisted vitrectomy. And most important thing, tell them fishing is allowed only in waters and not in the vitreous. And also important is counsel the patient and attendants, tell them everything is okay, the vision will be restored soon. And I hereby describe one technique which I call spade and candy technique, just like as you eat the candy round and round and get to the core of it. Here is a technique which I explain. This is a hard nucleus you can see in the vitreous cavity with some cortical pieces. And then after a good vitrectomy, you can see I'm trying to see there's a mobility of the nucleus. So I'm just opening the sclerotomy, enlarging one of the sclerotomies into a 20 gauge sclerotomy. Then going with the frag with the suction mode, trying to lift it into the mid, because there's a full nucleus and a hard nucleus. So I'm just lifting it to the mid-vitreous cavity. You can see the hard nucleus, the amber color of the nucleus. And then once immediately you have to, sorry about that. And you have to tell your assistant to remove the biome so that you don't drop the nucleus. You're holding in a suction mode. And through the other sclerotomy, I'm taking a 23 gauge MVR. And then you can see that I'm piercing through the center of the nucleus and just holding like a spade. Once the nucleus stays at this, I have done almost around 10-15 cases. You can just go around and around with your fragmentome and try to eat the pieces. My anterior segment colleague would have dropped, but my spade technique, I have never dropped a nucleus. You can just go around and around and eat all around the nucleus fragment there. And you can see still I have not induced the PVD there. You can see some remnants sticking onto the surface of the retina. And then I go ahead and then after removing all the pieces, then I just go induce the PVD. So as a VR surgeon, I would like to complete that as well. And then look for the periphery. And then the choice of IOL, here I'm doing a glue technique. Thanks to Amar Agarwal, this glued IOL technique, I've been doing it for the past 4-5 years and it's working out well. So the choice of IOL depends on the capsular remnants, everything. And there's a glued IOL technique. I'm not getting into the details of it. And that's the end. And that's why I call this as a holistic approach, because here you have to deal with the not only the patient and the attendants, but also with your colleague. Thank you.
That's a wonderful presentation.
Well, you have to unmute yourself, I guess.
Yeah. So good presentation. Yeah. So, very good presentation, Dr. Kasi, and a wonderful video also. We'll move on to the next presentation. Dr. Manoj Khatri from iDocs Hospital. Anterior vitrectomy for anterior segment surgeons. What every surgeon should know.
Yeah, good evening, everyone. Are my slides visible?
Mm-hmm. Yeah, visible.
Yes. Okay. So good evening, everyone, and thanks Team Reticon for the kind invitation. I will be speaking on anterior vitrectomy for anterior segment. Basically, all the ophthalmologists, not only for anterior segment surgeon. No financial interest in my talk. Basic key here is we should first, try to avoid this problem to occur. So you make sure you're always in your comfort zone. And if at all this problem occurs where you need to go for a vitrectomy setup, then you should be familiar with the machine, what you are going to use, and what is the extent of the damage, and how best you can manage this patient. So this is point number one. Point number two is this problem can occur. The vitreous loss and posterior capsular tear can occur at any stage. So you should be very careful. As you can see here, the surgeon is not aware that he or she has already caused a PC tear, and the implantation of IOL into the vitreous cavity is going on, which can be easily avoided if you are little careful and try to assess each and every step of your surgery. So the basic take-home message, point number one, is early recognition is the key. As you see here, we have noticed that there is a PC tear, there is a vitreous upthrust which is happening here, there is an irregular AC, and there is thrust which is happening. So slow down all your phaco parameters. If you're not confident, just use a side port injection of high molecular weight viscoelastic. Use a very low suction, and if at all possible, you can complete the case. As you can see here, we are injecting high molecular viscoelastic to push the vitreous space back, and also try to minimize the complication, and bimanual approach is the key. So the second take-home message here is bimanual approach. How we do a bimanual approach? What do you mean by bimanual approach? So you have an irrigation and aspiration which you need to separate. Another case where we noticed at 6 o'clock, this was a planned toric IOL, but you can see here there is right at the 6 o'clock there is a PC tear which has happened. We have slowed down all our parameters, including your phaco settings and also the suction. Try to minimize the extent of the PC tear, and you can easily chop this nucleus pieces and take it out in your phaco probe. And once you do this, then the rest of the surgery becomes quite easy. How to do a bimanual approach, we will see with this case. This patient has a PPC, that is a posterior polar cataract. This was kind of a PC defect which was anticipated in this patient, but what we did here is we just put high molecular weight viscoelastic and take infusion cannula in your one hand and the cutter in the other hand. All phaco systems has antervitrectomy cutter. The only thing is that you need to keep it in mind, your foot switch settings. It is same as your phaco settings, But the second take-home message here is use of triamcinolone acetonide. Diluted IVTA has to be used, but try to make some amount or try to do some amount of vitrectomy before you use IVTA. Always try to be in the center of the pupillary margin. This is the point number 3, which I want to tell all the audience. Try to be in the center. Don't try to chase the vitreous. The vitreous will come to you. You don't have to chase the vitreous. Try not to extend the PCR, which has already happened, and do a thorough wound toileting and suture all these wounds. So this is point number 3. The last thing what I wanted to share here is what we have modified approach over a period of time. This was a case which was done earlier about 2 weeks back, then referred to us for a further management. You can see a large PCR with a decentered IOL. But intraoperatively also, whenever you have a PCR, we are recommending now, and in spite of doing a limbal approach, do a pars plana approach. Pars plana approach of anterior vitrectomy. How we are going to go about this, I will just share with you in a couple of minutes. One second. So what we have to do here is we have to use either 23 or a 25 gauge trocar system cannulas, which is available with most of the dealers now. And you are going to do either a straight or an angle entry. Here we are using 25 gauge. You can do either with a 1 port or a 2 port. If you are doing 1 port, that means your infusion has to be in the anterior chamber. If you are doing 2 port, your infusion can be in the vitreous cavity, and your the second hand is of cutter. The illumination what normally vitreous surgeon use, we don't need it. So here, sorry again, mouse is getting stuck with this zoom. So here what we have done is we have used 2 port. There is an infusion here and the cutter port will be used here. The advantage of this technique is there is no vitreous upthrust, and you can have a much more controlled environment, and there is no pulling on the vitreous. What are you going to do? You are going to cut vitreous from behind. So there is very, very less traction on the vitreous base. As you can see here, the cutter always stays in the center of the pupillary axis, pupillary margin, and there is no or minimal traction at the vitreous base. No evidence of iatrogenic retinal tears, giant retinal tears, or retinal detachment, and you are in a much more safer and a controlled environment. You did not be a retinal surgeon to do this. Any ophthalmologist or any anterior-segment surgeon can do this. So this is what we are advocating nowadays, because we are in much more controlled environment. Eye is not hypotonous at any point of time, and you can do a good vitrectomy with and without use of triamcinolone. because nowadays the visualization systems are also improved quite a bit. So most of the times we are getting away without the use of the transferrin acetonide. So this was my point number 4. And the point number 5, because it's just a 5 minutes talk, never panic in these situations. Try to assess each and every step, what went wrong, and try to give the best optimal management to your patient. I thank each and everyone from the audience, and also thank Abhay Vasavada sir, Amar sir, Mohan Rajan sir, dear friend Ashwin and Nivian for these techniques which we have improved over a period of time, say about last 5 to 7 years. Thank you for a patient hearing.
Thank you, Manoj. Our next speaker is Dr. Srinu Prasad, Professor of Ophthalmology from Shui Chin Lee University, USA. He is our keynote speaker. Now we are moving to Dr. Srinu Prasad, sir.
Welcome, Srinu.
Good. Thank you. Good morning. Are you able to see my screen?
Yeah.
No, we're not able to see your screen.
We are not able to see your screen, sir.
Oh, you don't see it?
Yeah, we're not able to see, Srinu.
You have to share. You have to go to the.
Okay, share screen. And then see Microsoft.
Click on your presentation and then put share.
Okay.
Yeah, first click on your presentation.
Oh, there's some sort of security issue. Let me see here. I'm getting a security error. Should we go on to the next lecture before, so we can save time while I figure out the security issue on my end? It's saying that Zoom US will not be able to record the contents until it's quit.
Atul.
Okay, sir. Right. Then I'm inviting Dr. Nilesh, and he is from Dr. Agarwal's Eye Hospital. And
I'm getting a security error.
MIVS. Dr. Nilesh, please.
Yeah, good evening, everybody. And at the outset, I'd like to thank Ashwin and the Reticon team to allow me to be part of this great Reticon conference. I would like to be short and sweet. And there was one unique case. I'm sharing my screen.
Not able to see, Nilesh. Yeah, okay, fine.
Yeah. Is it fine, sir?
Yeah.
Fine, Nilesh.
Okay, fine. So this was one of the cases wherein the mission was kind of impossible. This was a young 22-year-old male who came to us with a cricket ball injury. And he had gone to many places wherein you can see a nice LASIK flap which was a bit torn, and there's an epithelial ingrowth. So anterior segment colleague was always present next to me. And you can see traumatic metriasis. What more? Now this patient was just given oral prednisolone tablet and some steroid drops. And the retina, you can see, after dilatation, the great difficulty was able to doubtful shallow RD in the periphery. So what? We did the B scan. The B scan, you can see nice shallow RD. So now we have few more things coming up. So what is now? We are able to see the subluxated lens, traumatic metriasis, and you can see many complications which may happen. So we are practically sitting in a hot seat. You can see I'm trying to place, of course, cataract has to be removed in this case for the better visualization of the retina. We are trying to keep endocapsular ring, trying to fix the zonules. Now here you can see visibility is little bit poor. Now with the help of the hooks, we are trying to put it in a nice way and fixing, yes, ECR in the place. Of course, there was one place the dialysis was there, but hope the things are going fine. Trying to remove the air bubble, inject viscoelastic, and now placing of intraocular lens, a very important part as far as this surgery is concerned. So once the IOL is placed nicely, endocapsular grid, of course, gives a nice compartment wherein we can place the intraocular lens. Now we have to, anterior segment will be done at the last. So once IOL is done, the most important step is over. The next will move into the retina. You can see here there's a giant retinal tear. So let's see what more things are happening and what more things are coming on. So we went with a thorough, of course, MIVS gives a very good platform in this kind of surgeries where we did a vitrectomy was done, and you can see the giant retinal tear now back in the place with the silicone oil, and the scleral band was put here. Now this is with the MIVS, we can do all the things nice and safe. Now, of course, the best technique is, you must have heard about the pinhole pupilloplasties and pupilloplasty. Now, this is a traumatic case where the pupilloplasty is very, very obvious. And of course, last and the least, we are going with the corneal flap elevation because we need to remove this epithelial ingrowth. Anterior colleague was right next to us. We can go slowly, gently lifting up the flap because this patient was a high myope. And basically, the flap was also thin and trauma makes this really difficult. Very difficult to differentiate. This patient was advised keratoplasty at many places. We thought, let's try to lift this thin flap gradually so as to remove the flap nicely and remove the subepithelial ingrowth from it. Yeah, so now we can see the flap coming off. Of course, last and least, let's say the case is going to be over, trying to remove. And yes, again, a basic technique of switching off the microscope light and seeing the endometer. Now we are trying to clean the flap, but see what happens. The flap also comes off. So practically, take the name of the complications and everything is available in this, a kind of a textbook on its own, trying to replace the flaps. Of course, marking would have been helped us to place the flap properly. Sutures are being placed at all the places and so far things went well. And this is the post-op picture, day 1. Thank you very much. Thank you, sir.
Thanks, Dr. Nilesh. That was a wonderful presentation.
Next.
Sinu, things are sorted out?
Yes, I should be ready right now.
Okay, then I think that you are the next.
Yes.
Okay.
Okay.
I'd like to take a moment first of all, to thank the Reticon 2020 team in organizing this meeting, and also the Agarwal family for the kind invitation to present at this meeting. I'm really astounded at the quality of the lectures and the wonderful people. It's nice to see so many familiar faces from my homeland. Now, the first lecture I'd like to give is on the utility of intraoperative OCT in vitreoretinal surgery. And this is a very humble perspective that we've had in having the Leica intraoperative OCT machine for the past 3 years. Very simply, it teaches me about the anatomy of the back of the eye. Having done this for 15 years as faculty at University of Chicago, it's always nice to be fascinated by new things. And I'll show you a few examples from our clinical experience. And also we have trainees, fellows, residents, and it's so nice to show a visual representation of what we're trying to explain verbally. And there's a way to objectively document how we do things and how we perform surgery, which is very useful from an educational perspective. But also it enhances patient care. And this is somewhat nebulous. It's hard to quantify how this enhances patient care, but I'll show you a few examples, especially in the setting of tractional retinal detachment repair, membrane peeling, where this can be advantageous. So we use the Leica and focus surgery, which is very useful from an educational perspective, but also it enhances patient care. And this is somewhat nebulous. It's hard to quantify how this enhances patient care, but I'll show you a few examples, especially in the setting of tractional retinal detachment repair, membrane peeling, where this is shown. Now, the most common usage or most common surgery we do are focus surgery, which is very useful. Beautiful definition of the scar tissue on the surface of the retina. Now, the first step in our surgery, we always use dilute triamcinolone acetonide to highlight the epiretinal membrane. And keep in mind, we have trainees and we're teaching them how to perform surgery. So this technique is very useful, and you can see the triamcinolone crystals highlight beautifully on this technology. And then with a very simple pinch and peel technique, you can see the hyper-reflective prongs of the forceps, and we pinch and peel the epiretinal membrane off the surface of the retina. And you can see the scar tissue start to come off very nicely with this technology. And it starts to lift up. And you can ensure that you have a very complete peel off the surface of the retina. But the real beauty of this technology comes with tractional retinal detachments. notice how you can so beautifully delineate the tractional retinal membranes from the point adhesions on the surface of the retina, and the hyperreflective thing moving back and forth are the prongs of the forceps. But you can see the point adhesions so nicely, and as you pull the membranes, you can see them be relieved from the surface of the retina, and you can see the membrane start to peel away to have a clean surface, and you can be ensured that you removed all the membranes. And obviously for a seasoned surgeon, this technology may not be necessary, but you can imagine from a trainee perspective how valuable this is. The other benefit are in retinal detachment repairs, and this is one of several examples of how you can use this technology to quantify subretinal fluid. So this is a pre-retinal detachment repair intraoperatively, and then after draining the subretinal fluid, look at the nice resolution of the subretinal fluid after drainage. Now, what do you all think this unidentified floating object is? UFO, it's not an unidentified flying object. And this is actually a dropped intraocular lens. And you can see that we can so nicely delineate the architecture of this lens on the surface of the retina. I'm sure many of you have never seen an image like this. And as we pull it out of the eye using some heavy forceps, look how nicely this intraocular lens can be pulled out of the vitreous cavity through the sclerotomy. I wonder if you all know what this is, and this is not some corneal dystrophy, but rather a patient who presented to me with a pressure between 50 to 60 and had retained silicone oil that was emulsified and was in the anterior segment of the eye. And so obviously we had to remove this to relieve the pressures. And we used a small, a short 25 gauge needle, and look at the resolution using intraoperative OCT to remove the silicone oil from the anterior segment of the eye. And then you can document that we were successful in our procedure, and really nice removal of the silicone oil particles. This is an epiretinal membrane case, and we noticed that right behind the lens, we could visualize the posterior capsular opacity. And it's a very nice image where you can see that after using the retractor to remove this, we can document a beautiful crystal clear lens sparkling after the posterior capsular opacity is removed. So it's a very nice way to document things we do surgically. Is this technology absolutely necessary? Of course not. But you can imagine from a training perspective and, as a seasoned surgeon, to see these structures in a different light is a very nice thing. Now, at the beginning of the fellowship, I always tease my retina fellows, especially in a diabetic case, after they do vitrectomy surgery, I ask them, did they finish the vitrectomy? And of course, the answer is obviously yes. But I humble them by injecting triamcinolone, and we can show how much vitreous they left behind. And this is an example where triamcinolone can be used to highlight the hyaloid face, showing the retina fellow how much vitreous they left behind. And these are all for educational purposes, but also for the seasoned surgeon to ensure that vitrectomy was complete. This is another example of seeing things in a different perspective. This is a patient who had retinal detachment, actually a tractional retinal detachment repair, and doing endolaser. Look at the poof of smoke that we see captured on this technology, and really what this is. There's no value per se to the patient, but to be able to capture this finding is really spectacular, showing the power of this technology, seeing the poof of smoke from an endolaser being applied. Now, Dr. Kasanathan will relate to this. This image is not of a choroidal tumor, but rather a sublux native lens in a Marfan's patient. And we look how beautifully we can capture the depth of focus of this technology from the surface of the retina all the way to the top of the sublux native lens. Is really fascinating to see this depth of focus and the clarity of the layers of the sublux native lens. So the technology, in my opinion, is still in its infancy. We have a long way to go. There are many ways to enhance this technology. First of all, imagine injecting the OCT images into the oculars, and rather than looking at a separate screen. Foot pedal intraocular OCT control integration would be very helpful, but also easier setup with less effort to acquire the images during the case. Right now, we need a separate person to help acquire the images. Higher resolution is always appreciated, but data management is a very serious problem with this technology. These images are massive, and just managing the data and working with the videos can be a challenge with the current technology. Thank you so much for your patience while I dealt with the technological issues, and look forward to the rest of the lectures.
Thank you, sir. Thank you so much. That was wonderful to watch. Intraoperative OCT's excellent presentation, sir. Thank you so much.
Well, thank you.
Let's move on to the next presentation. Our eminent speaker, Professor Dr. Nadarajan, sir, Chairman, Founder of Adityajot Eye Hospital, Mumbai, managing the monster, suprachoroidal hemorrhages.
Thank you, Dr. Pandivel. So I'll just share my screen. It's always great to see Sinu. Nice to see you here. I think it's difficult to present after you present. I mean, always a great presentation. Can you see the screen?
Yes, sir.
Okay. So thank you. Thanks to Amar and Ashwin and Atul for having me here. They are a part of the trial celebration of the 30th anniversary of Adityajot Eye Hospital, Singapore National Eye Center, and St. Eric's Eye Hospital. So my topic is managing the DEMON, the explosive hemorrhage. Here we have a 76-year-old male who had an injury and came with an iridia after a primary wound repair done elsewhere. So here you see I'm doing the 360-degree perimetry, tagging the muscle, making sure that the intraocular pressure is maintained. But in spite of that, I'm actually injecting the viscoelastic into the antechamber to make sure intraocular pressure is fine. I'm doing a scleral tunnel. And I don't know what happened during, if you will be seeing shortly, during vitrectomy, suddenly you see a big mound. And the first doubt was whether the intraocular infusion line was in line or not, or whether it was in the vitreous cavity or not. But while doing, I think the big mound happened, detachment was increasing, choroidal detachment happening. And then I think by the time I realized it was actually an explosive hemorrhage happening. In spite of managing a lot of explosive hemorrhage, still I think it was it took a few seconds by the time there was a total retinal detachment happening, choroidal detachment happening. So I tried injecting PFCL oil to make sure that the thing stopped there. But as usual, you know that during vitrectomy, it's always a problem. And I think the idea was to make sure the intraocular pressure is kept on the half side, and then make sure the wound is closed. Since it was a 23 gauge, after increasing the pressure, I went back to see, but you can see already a severe choroidal detachment, and I think I couldn't proceed more. So I left it at that moment, and then went back about 2 weeks later. So you can see after 2 weeks, you have the eye quiet with the vitreous hemorrhage, and then 2 weeks later, again, I do a 23 gauge infusion line I make. So do a vitreous lavage, so there was the altered blood, which was on the anterior part of the anterior chamber and vitreous cavity. And with the initial fluid coming, it was a vitreous lavage. And I actually earlier put a band, but that also I removed. And then I cleared the vitreous hemorrhage using the retinal brush, use the extrusion needle, and clear the blood from the anterior chamber, anterior segment. And now you see a large tear on the temporal side, and that total retinal detachment. And you can see the infusion line in position, and trying to trim the residual vitreous which was left behind. And then I'm going into the subretinal space, and then you can see like a golden bubble, and that's the heavy oil which I'd used, which actually went subretinal, and I'm removing the subretinal silicone oil, and I have to use a high pressure in the viscous fluid extractor connected to the machine and removing the silicone oil, because the heavy oil always settles down, and now through the retinal break into the subretinal space, almost close to the macula and optic nerve, and I'm clearing the surface of the choroid, and then now opening up the funnel, removing again the vitreous from the posterior pole. I'm doing a fluid air exchange, endodrainage, and I saw a macular hole there. So I decided not to use PFCL, because I know the PFCL will go through the macular hole into the subretinal space, which I wanted to avoid. So I didn't use PFCL at all. So I have started doing vitreous surgery before PFCL era, so we know how to manage. So without traumatizing, I went through the macular hole, did an endodrainage. You can see the retina is getting separated and made sure the retina goes flat. And then the only thing is, I don't recommend to any beginner without experience not to go through the macular hole. And I did it to make sure that there's no subretinal fluid in the posterior pole. And I also did laser around the macular hole. And you can see this at the end, this is the fundus picture, laser done around the macular hole, and also the peripheral break. So the patient, he was an 85-year-old patient, had about counting finger close to face, but they otherwise all right. Always use this as a stepney. This was a 72-year-old female while doing a cataract, one-eyed, a senior-most cataract surgeon in Mumbai was doing, and he called me. I told him close the case and then send it to me. And this is what you can see the remnant of cataract, which is I'm infusing the antechamber with viscoelastic, then use the AC maintainer and did the clearing of the anterior segment through the other one of the through the limbus, and then I make sure that I clear the vitreous hemorrhage in the anterior segment as well as in the pars plana region, and then make the 3-port pars plana entry, and through the pars plana, through the trocar, I drained the suprachoroidal hemorrhage and then cleared the vitreous hemorrhage, use perfluorocarbon liquid, and also make sure that the subretinal suprachoroidal hemorrhage was drained, and also the subretinal was drained, and the retina was totally attached at the conclusion. So this was the fundus picture. You see optic disc pale, but the vision was 624, and 3 months later we removed the oil. And this was an eye which had undergone the video is not working. Okay, so this is again another eye. I'm sorry. So I think the 2 more eyes where the video is not working. Thank you very much. So I think if there are expulsive hemorrhage happening, and my suggestion is not to give up, and I think we should do 1, 2, or 3 surgery. Make sure you drain the fluid, and I usually wait for a week to 2 weeks, do the suprachoroidal hemorrhage, drainage, and then continue with the vitreoretinal procedure, and make sure retina is attached. At least anatomically, you should get the best, and also functionally, whatever best you can. Thank you very much.
Thank you, sir. That was amazing. Challenging cases, wonderful surgeries and videos. Sir. Thank you so much.
Thank you.
Yes. So we'll move on to the next presentation. Professor Dr. Gopal S. Pillai, Professor HOD and Chief of VR Services, Amrita Institute of Medical Sciences, Kochi. The topic is tips, tricks, and traps in macular hole surgery.
Thank you very much. Am I audible?
Yes, sir.
Yeah. So I will just share my presentation. Okay, so macular hole surgery is always a journey. Right from, 2002 onwards, I've been doing macular hole surgery. And earlier, we were just doing ILM peeling. And at that point of time, there was no staining. And then we used triamcinolone for staining. And then slowly, we moved to indocyanine green angiography. And then finally to brilliant blue green. So in between, we had used, trypan blue. So this is a case in which there is a completely detached flap, which I'm just introducing into the hole. It's like we are putting it into the hole, and then the rest of the ILM is being removed. So we have actually moved on between ILM peeling only to inverted flap technique, which Dr. McCloskey will be talking about here. And then this is one case in which easily you had put in the flap inside and then it closed with a wonderful closure. This is again another hole in which this is a slightly larger hole. You can see this. And now always I use a pinch and peel technique to take the ILM. And then the first peel is towards the hole so that we get an edge. And from that edge, I take in. And this is another, we are moving into a small petal. And this petal, I am just putting it on top. So like that, we can use multiple petals to close. This is another technique which I later on tried. So multiple small petals like this, you could put it on top of the hole. So this would be just on the surface. Would not basically put in, but the problem is many a times it will not stay there, and we may require to use a high viscosity viscoelastic or even a drop of blood at the macula to just keep it there. So from multiple areas you can see that multiple petals, all these petals were being taken to the area of the hole. Okay. But later on, I realized that that is not required. And then, when you have more ILM into the hole, then what happens is that there will be a central abnormality and that will affect our functional equity. And then we realize that only one particular area, you need only a little part of the ILM as a scaffold on top of the hole. You do not require the entire ILM inside. So one small area we would put in there and then keep it there just on the surface. You can just scratch it into the surface, just fold it into the surface and keep it there. And the rest of the ILM, let it be there. There is a hinge there, so even if it is going out, the rest of the ILM is removed slowly. And as usual, we will remove arcade to arcade. I generally try to remove arcade to arcade in all cases, so that there is no doubt about it. In the second or any time where there's a macular hole closure, we are not any concern that we have not closed enough. So a little bit of ILM is just put there. That was the next sort of a technique. And you do an air fluid exchange. I usually use a gas. I usually use SF6. You can see that even then the RP is slightly changed. Now this is a patient who has an epiretinal membrane also. So initially what I do is I try to make a small flap of epiretinal membrane. And when you have that flap of epiretinal membrane, some of the ILM and ERM are disturbed. And then when you stain, you can see the negative staining here. The central area has the epiretinal membrane. I always go from the periphery, hold on to the ILM. Maybe you can stain again and again. And then once you hold the ILM in the periphery and then move towards the center, definitely the ERM will definitely come out of it. And then using that ILM, you make that particular thing and then now close the hole. Then another case, this also closed without a problem. Now this is another case in which there is a retinitis pigmentosa with a sudden decrease of vision. Actually the retina was quite atrophic, but he was having a documented vision of 6/60, which fell down to 3/60 when I decided on surgery. There was an epiretinal membrane again. This does not look like a normal, this is an ERM plus ILM, which we have removed. And I will usually, if there is a lot of ILM or ERM like that, then what I do is I will basically trim off the central area with a probe so that there is only a little ILM. Now I think actually that ILM bit is also very less there, and we had a closure. So finally we realized that if it is a large hole also, sometimes what happens is that even if you put in the ILM, the closure initially is not really great, but with time, like for example, you can see here that there is still ILM there, which slowly closes over the next 3 weeks. So this also has now you can see that this is much better. Thank you very much.
Thank you, sir. Thank you. Wonderful surgery, sir. Nice presentation, sir. Thank you so much. Let's move on to our last presentation. Dr. Sitish Kumar, Disha Hospital from Kolkata. Newer perspectives and management in the diagnosis and management of lamellar macular hole.
Dr. Kshitij, we cannot hear you. Dr. Kshitij, we cannot hear you.
Yeah. Am I audible now?
Yeah.
Yeah, now audible.
So at the outset, I must thank Reticon Organizing Committee for giving this opportunity to present on such a larger platform with such eminent speakers. And I'm here to present on lamella macular holes. So the International Vitreomacular Attraction Study identified the following 4 features, of which the first one is the foveal thinning with irregular foveal contour, breaks in the inner layers of the fovea, intraretinal split, and the absence of a full thickness foveal defect. So briefly looking at the mechanism of hole formation, in case of a macular pseudohole, it's mainly the centripetal traction of the epiretinal membrane, whereas in case of a lamella macular hole, it starts with a centrifugal contraction of the vitreous, which leads to a dehiscence of the inner retinal layer from the outer retina, and this is followed by contraction of the epiretinal membrane. And it was in the year 2016 that Govetto et al. Classified the lamella macular hole into a tractional lamella macular hole and a degenerative lamella macular hole. And this change led to a paradigm shift in the understanding and the management. So if we look at the degenerative lamella macular hole, it's one which is associated with a lamellar hole associated epiretinal proliferation, which is also labeled as atypical ERM. And these type of holes have poorer visual acuity, larger hole diameter, round edged. They have invariably disrupted ellipsoidal zone, and the surgical outcome is not really good in such cases. Whereas in case of a tractional lamellar hole, it is associated with a contractile ERM, and this leads to stasis like cavitations inside the retinal layers, and these are associated with good visual acuity and with an intact foveal photoreceptors. And there have been several controversies around lamella macular hole. That is, the natural history has controversy, the interventional outcome has controversy. So if we look at the natural history, then Theodosides and et al., they found that the hole progresses in diameter as well as the visual acuity deteriorates, whereas Fernandez et al. Show that it does not progress morphologically and functionally. And over the past decade, Botany, Mishulaska, Zampedri, and Govetto et al. Show that it's a stable and a slowly progressive entity, whereas Pang and Theodosides showed that it's a progressive entity. And the Pang in their study found that almost 18% of cases which are associated with epiretinal proliferation would progress morphologically. However, the Govetto et al., they found that both the degenerative and the tractional variety, they do not progress in terms of visual acuity or macular thickness, whereas Compera et al. Show that if there's a LHEP, then the diameter of the hole increases with a deterioration in the ellipsoidal zone. So that was a controversy around the natural history. What if you go to do intervention for lamella macular holes? Again, there are a lot of controversies, and studies like Reticon et al. Show that 13% of cases would have a full thickness hole formation of hole after surgery, and the vitrectomy is not that advantageous. And of the various types of epiretinal membrane association is the pseudo-lamellar hole variety, which does not improve significantly following surgery for epiretinal membrane. However, Lee et al. Showed that in almost 60% of the cases, the visual acuity would improve. The same was found by Godric et al. That both the macular pseudohole as well as the lamella macular hole, the visual acuity and the morphological outcomes are good. In my study, which I published in 2016, of the various type of vitreoretinal interface disorders where we did a double membrane field, it was again the lamella hole variety which did not improve significantly in terms of visual acuity following surgery. So if we look in terms of the perspective of a tractional and a degenerative lamella macular hole, and if you do a double peel of epiretinal membrane and ILM removal, then Parolini and others showed that there is significant visual acuity gain. Utra showed that it doesn't improve in terms of visual acuity, and Co and others show that it's only the contractile ERM variety which would gain in terms of vision. And again, Parolini and others showed that if there's an atypical ERM or LHEP, then you may end up having a full thickness macular hole formation. Therefore, for tractional lamella macular holes with a contractile ERM, a double peel should be the preferred approach. Whereas for a degenerative lamella macular hole with atypical ERM or LHEP, the double peel doesn't help in terms of functional or the morphological outcome. And on the contrary, you may end up having a full thickness macular hole, as shown by Krishna et al. In this study. So there was an unmet need for an alternative technique for degenerative lamella macular hole, and this new technique is defined as LHEP or AERM embedding technique. It was the base rationale behind it is that the LHEP is composed of Muller cells and inner retinal tissues, and they, along with macular pigments. So its embedding into the defect would lead to a therapeutic effect. And it was first described by Shiraga in 2013, who did ERM flap embedding with ILM removal in almost 20 cases with good functional and morphological outcomes. And the same group modified the technique by doing the ERM embedding and covering it with a superior ILM flap. Again, a good functional outcome and morphological outcome was achieved. And Frisna et al. Came up with a very large series, and they described a double flap of ILM as well as ERM, and they embedded into the defect. And in almost 30 eyes, the visual acuity improved with no further complications. So I have had my fair share of history with laminar macular holes. Initially, I used to do a double peel, and this was a tractional variety where the visual acuity as well as functional outcome was good. Another case, again, the morphological outcome was good for tractional variety. And these were the degenerative ones which did not do well with the double peel. However, I switched to a double inverted flap technique, and ultimately we had a good foveal contour recovery in cases of degenerative laminar macular hole. Again, in this case as well, we can see a good anatomical and functional outcome. Thank you.
Thanks, Dr. Satish. Thank you. We have come to the end of the session. All the wonderful presentations, beautiful videos. Thank you for all the eminent speakers for keeping up the time. So thank you all. Thank you so much. Let's move on to the next session. Atul, would like to say something?
Yeah, very nice presentation. For the next session, the panelists are Natarajan sir, Lalit Verma sir, Gaurav, and Rakesh. Gaurav, take over as a moderator, please.
Yes, sir. So as we all know that we are in the middle of the innings and the power plays are over. So let us welcome you all for the third session, which is retina surgical. And that's a request to all the panelists, please stick to the time. And all the best to all the speakers. So we welcome Dr. Subhendu Kumar Boral, who is from Disha Eye Hospital, Kolkata. So he's going to speak on submacular hemorrhage management.
Hello, can you hear me?
Yeah, Boral, carry on. Shubhendu, carry on.
Yes. So submacular hemorrhage management all depends on the size of the submacular blood and as well as the duration of hemorrhage. So next slide. It's not. Hello. Hello. It's getting locked. Hello. Can you hear?
Yeah, we can hear. We can hear you.
So we can hear you.
If it is small size, yes. If it is small size, less than 4 disc diameter, less than 2 weeks duration, like in this case, where small hemorrhage amount of hemorrhage due to the CNVM, or it is post-traumatic, one injection of anti-VEGF is enough, or pneumodisplacement is enough. But if it is medium size, more than 4 disc diameter, but not extending beyond the temporal vascular arcade, it is the ideal situation for subretinal TPA. A lot of controversy between the intravitreal TPA or subretinal TPA. Subretinal TPA is definitely has more value. 50 microgram in 0.05 ml, it is injection actualized. It is I'm just advising, like ideal situation is more than it is just beyond the foveal, it is foveal contour, foveal fovea, and so that any clot lysis can displace the blood from the foveal side, and patient can gain the vision. And it is a case of sub-neurosensory sub-RP hemorrhage, which vision is mounting close to face, and I'm using cocktail of subretinal TPA here. After doing vitrectomy and PVD induction, I'm just inducing blob-like elevation serous detachment with the help of injection subretinal TPA. Here I'm directly injecting the PED TPA, although it is not very much well recommended, but still I'm waiting here. Then followed by injecting subretinal anti-VEGF injection, ranibizumab, as well as subretinal air injection to displace the blood, then asking the patient for the proper position. And after 1 month, you can see the beautiful picture, total resolution of both sub-PED and sub-neurosensory retinal detachment. Like in this case of sub-neurosensory retinal detachment, hemorrhagic detachment with, I'm injecting subretinal TPA here, and then creating small retinotomies paramacular and to drain the lysed blood after injecting subretinal TPA. 2-3 areas are sufficient to clear the all blood, then settling the retina and doing laser injecting anti-VEGF injection followed by oil injection. And after you can see the in the follow-up patient ultimately gained 6/18 vision after silicone removal. This is a combination of sub-ILM hemorrhage, post-macroaneurysms, as well as subretinal hemorrhage. And after doing vitrectomy and PVD induction, I am just filling the ILM to release the trapped sub-ILM blood here, and then planning to inject this subretinal TPA with the help of 41 gauge metallic needle. And just only subretinal TPA suffices here in this kind of situation. After 1 month, you can see this the subretinal blood is almost vanished. Like in this case of hemorrhagic retinal detachment is a quite complicated case. Blood is very much tenacious in this kind of situation, and you can see the total hemorrhagic retinal detachment here. So I'm injecting subretinal TPA with 38 gauge subretinal cannula needle at multiple quadrants, but not beyond the recommended dose. Then doing retinectomy, temporal giant retina tear, removing blood, then injecting PFCL to settle the retina, and you can see that I get that nice result. And finally, I'm doing the silicone PFCL exchange. And finally, after silicone removal, patient gains 6/36 vision. Now here in this, if the blood is very much old, or you have already given multiple injection of anti-VEGF, like in this case, you have to go for the subretinal blood removal as well as RP chloride graft transplantation. So this is the initial step, injection of retinal detachment. Then when the retina is already elevated, like in this case of hemorrhagic retinal detachment, then I'm doing temporal retinectomy. Although peripheral retina cauterization is not necessary, as because it is less vascular. Then removing the subretinal blood thoroughly, but take care of the overlying retina. You should not create additional break. Now this is the subretinal fleshy neovascular membrane. Is a case of PCV. Taking care of surrounding retina, remove all the additions, and this kind of fleshy neovascular membrane, you have to remove it and remove the residual blood. Take the cauterize the feeder vessels to prevent the further subretinal hemorrhage, recurrence of hemorrhage. Now we are planning for RP chloride graft transplantation, so injecting PFCL to remove the keep the retinal flap away from your working site. Then take the cautery, take the graft area and remove the blood, remove the graft, move the blood, graft under the PFCL and inject, place it and remove the PFCL, inject the PFCL over the retina and do fluid exchange, and ultimately do fluid exchange followed by silicone oil PFCL exchange. Now these are some good results. Now I am highlighting one very interesting case where I did vitrectomy and followed by subretinal TP injection, followed by subretinal anti-VEGF and filtered air 0.03 cc. And after doing this kind of intervention, patient gained 6/24 vision. But again, after 14 weeks, again he presented with recurrence of subretinal hematoma. So in this situation, I planned for the RP chloride graft transplantation. Following, like in this case, I inducing the retinal detachment, then removing the blood, creating GRT, and removing the subretinal blood, and then taking the graft from the relatively healthier looking area, subretinal PFCL. Under the subretinal PFCL, I am moving this graft under the PFCL into the proposed side of the fovea, and then placing the graft, removing the PFCL, again injecting PFCL, overlying the retina, placing the retina, and then doing fluid exchange followed by silicone and PFCL exchange at the end of the session, and possibly you can get a good kind of vision like this. Thank you. Hello.
Thank you, sir, for the nice videos. Now I'll call Dr. Mahesh Humgam, who is going to speak on combined vitrectomy and scleral buckle for RD. He's from Shankara Eye Hospital, Bengaluru.
Thank you. I think Dr. Subhendra has to stop sharing. Good evening to everyone in India, and good morning and good afternoon to our international speakers. Thank Dr. Atul and Ashish for this opportunity, and the Agarwal team for this opportunity to meet you all virtually this evening. I hope you can hear me and see my slides.
Yes, sir.
Yes. Okay. So in the next 5 minutes, I'll be speaking about combined vitrectomy and scleral buckling for retinal detachment. What is its role? So if you look at the literature, most literature says there is no role. So on the left side, you can see so many papers saying that like whether we put the belt buckle or scleral buckling or do only vitrectomy, the results are the same. There is a very small, minuscule number of papers which says that scleral buckling and belt buckle helps. But then as a vitreoretinal surgeon, I have learned over the years that you should do everything possible in your hand to make sure that the retina remains attached. And if you want to go back home after a full day in the theater and sleep peacefully like a baby, you need to do as much as you can for any given patient. So when would I put a buckle or a belt buckle? Let's look at some scenarios. See, here we have a partial retinal detachment and a superior retinal break and a lattice in the inferior attached retina. So how would I manage this? There's no need for any encirclage. If at all, we can put an encirclage just to make sure that the anterior vitreous doesn't contract subsequently, but you can get away by just doing a laser photocoagulation to the inferior lattice in the attached retina and taking care of only the superior retinal break. Here is another situation where there's a total retinal detachment and the lattice is also in the detached retina. So what do we look for? We look for posterior vitreous detachment anterior to the lattice. So this vitreous anterior to the lattice, if it is detached, then it's easy. So we just circumcise it, leave the vitreous around the lattice, and there will not be any further traction causing the elevation of this particular lattice. So this is how it looks at the end of the surgery. But if the anterior vitreous is not detached, then I would support it with the belt buckle. So another situation where I put a buckle or a belt buckle is what you see here. This is posterior migration of the vitreous base. You can see the vitreous base up to where we can peel the vitreous is quite posterior. We are unable to peel the vitreous anterior to that. We can see some pigment clumps and contraction of the vitreous. This cannot be peeled with the forceps. This cannot be peeled with the cutter. In such a situation, once again, I would think of placing an encircling band to support it. Here I am using a 4 mm band for a broad coverage. So let's look at detachments with breaks. So here we have an inferior horseshoe tear. Once again, if the anterior vitreous, the vitreous traction from the hole to the vitreous base can be relieved, then there is no need for any encirclage or a buckle. So here is one such case. You see multiple HSTs. You can see the posterior breaks have been operculated. The anterior breaks have the flaps which can be removed. And if you're able to peel the vitreous anterior to the breaks for about like a half a disc diameter or 1 disc diameter, that means the traction has been relieved completely, and there's no need to support from outside with a buckle or a belt buckle. So in these situations, all we need, even if there are inferior breaks, is a good vitrectomy and tamponade. But if there is an inferior HST and adherent anterior PVD where we are not able to remove the traction, then I would think of putting a buckle, solid silicone, in addition to encirclage. Unless if it's a very small break, you can support it with an encirclage or a 42 band. So here is another situation. So this is a phakic base dissection is what I am doing. So anterior vitreous, we are able to peel it and remove the contracted vitreous, but despite all that, the presence of the lens, though we are able to dissect it almost up to the vora, the presence of the lens makes us a little bit like take adequate care in dissecting it, despite which we are not sure that we have peeled the vitreous adequately. And this patient, if you note carefully, also has a proliferation, a neovascular proliferation. It's a long-standing RD. Once there is a peripheral neovascular proliferation, the vitreous is attached to it, and it may be difficult to peel this off. In this situation, again, I would think of putting a buckle. So if planning vitrectomy plus SB, better to place the scleral buckling prior to entering the eye, because midway, if we were to change the plan, like we find during the vitrectomy that like there is adherent vitreous which we are unable to peel, and if you want to place a buckle, What I would do is to remove the cannula, place sutures, take temporary knots, and then go ahead with the scleral buckling. Because if you were to keep the cannula and go into the surgery, what happens is the presence of cannula limits the exposure to the sclera, and there is a risk of lens touch from the infusion cannula. And the infusion tends to go back when we're trying to place the suture, press on the eyeball. And this hypotony and increased intraocular pressure can increase the risk of choroidal detachment. So to summarize, when traction relief is inadequate or it is not possible surgically, then you would want to place a buckle or a scleral buckle. When there's a narrow anterior band of traction, a belt buckle would do. When there's a broad anterior band of traction, vitreous-based proliferation like the last case I showed you, large inferior breaks with persistent anterior traction, a scleral buckling in addition to vitrectomy is what would be preferable, particularly an inferior break. Thank you very much.
It was very nice presentation, sir. Nice, sweet and soft. Now I'll call Dr. Sengal Ozdek. She's talking on something very interesting, a pediatric of vitrectomy.
Thank you. Hello from Turkey. I would like to first thank to my friends Atul and Ashwin for this organization and to all the organizers of Reticon 2020. It's going very well, very high quality presentation. So now I will try to talk about the tips and tricks for pediatric vitreoretinal surgery in 5 minutes. Pediatric eye has some differences from adult eye. It's not only a very small eye, but there are some anatomical differences. Lens is relatively large, pars plana has not developed, vitreous is very tightly attached to retina, sclera is very thin and elastic, interpalpebral rim is very narrow, which doesn't allow you to move the eye, the maneuvers are much less. You see, the lens to vitreous volume is much higher in pediatric eyes, which makes some maneuvers difficult. And pediatric vitreoretinal surgery has different philosophy. It has its own rules, its own complications, does not forgive faults, and does not accept apologies. And when you have a retinal break, you usually end up with surgical failure. And PFCL and silicone oil are rarely used. Children do not obey the head position. Again, it causes some problems, of course. And PVR is really very frequent and severe when it happens. And in addition to all of this, we have also the amblyopia problem. The sclerotomy construction is one of the main steps in pediatric vitreoretinal surgery in a position in opposed to adult surgeries. Selection of sclerotomy site, number of sclerotomies are very important to determine. And you can use any gauge surgery, and you try to do lens sparing vitrectomy if possible, and you use pars plicata entry for this. But if not possible, then you should do lensectomy vitrectomy surgery. While trying to decide on the sclerotomy site, first you should decide on the sclerotomy distance from the limbus. We usually use 1.5 millimeter from limbus for prematures till 6 months, and then we increase the distance till 3 years of age, and then after 3 years, it's like adult cases. At the very beginning, we can do a lateral camtotomy to increase the, to widen the narrow space, to increase the space for maneuvers. And if we decided to do the lensectomy, we can use either iris root entry or limbal entry. It has some advantages and disadvantages. For iris root entry, iris root hemorrhage may be a problem. And for limbal entry, we don't need camtotomy, we don't need to do peritomy, and we avoid from the peripheral retinal damage. But it has some disadvantages like corneal distortion, endothelial damage, and you need to put tunnel features, which needs to be removed under general anesthesia. While trying to decide on the sclerotomy site, you should avoid from damaging the anteriorly pulled retina, so you should check the peripheral retina and the pars plicata area, and you should avoid from those areas to avoid from retinal damage, and you should suture all the sclerotomies. For this case, for example, the retina is pulled towards the temporal periphery, you need to put the infusion to the nasal side. Sometimes all nasal entries are also possible. And I always use 3-port sclerotomy, and by this way you can use the adult type instrumentation. You don't need anything additional. And I usually put an pre-placed suture to the infusion cannula to avoid from the post-op hypotomy. You can also use 2-port sclerotomy, but this lets you to have more space for maneuvers to move the eye, but you need additional new instruments with infusion line, like illumination with infusion or forceps with infusion. Those are, additional costs. And hypotony is another issue. And you need to do surgery for many diseases, but I will show you just one example of stage 4B ROP case. As you see here, I pre-placed the suture in the infusion line and put the sclerotomies, trocars. You can use trocar, or you may do it without trocars. And after you do central core vitrectomy, we try to peel the membranes, but if you feel that it may cause a retinal break when you pull it, just leave it there. You don't have to peel all the membranes. You just try to leave retina as much as possible, but when you feel a danger, please stop it. And you should be very, very careful while doing this, and you should decide on when to stop. So it's very important to decide on when to stop. And this is the post-op appearance of the same case. You don't expect the retina to attach during the surgery, but it usually attaches after the surgery. You just relieve the interactions. And this is the most typical surgery where the surgeon should know where to stop. And perfect is the enemy of good. We know that. And do not let any iatrogenic break. And if you have a retinal break, if it is in a silent area, you can continue with standard techniques. And if it is in the peripheral retina, you can put a scleral buckle in that portion. But if it is in the most proliferated area, like a rich area, I can abandon the surgery in such cases. And post-op hemorrhage is another important problem. To decrease the risk of post-op hemorrhage, you can use pre-op avastin to eyes with plus disease, for example, in ROP, and you can avoid peeling membranes in active stage 4A cases. And we shouldn't let any hypotony at the end of surgery, which may cause post-op hemorrhage. Fluid air exchange, I always do that at the end of the surgeries. Sometimes I even put some viscoelastics in the vitreous cavity. So my take-home messages are minimum non-nocere. So do not turn first. And do not start with pediatric cases before you are done with adult vitreoretinal surgeries. And scleroderma construction is very important for pediatric cases. Please try to preserve the lens as much as possible. Stop peeling when there is a risk of retinal break, and do not forget amblyopia treatment. So this is my real view. Actually, now I'm in the feast for Eid, and I wish a happy Eid to everybody. And I will go to beach after the meeting like this. So hope to see you again in person in Bodrum. Thank you.
Very nice presentation, doctor. And the key home message is that when to start and where to stop. That's what we should know in pediatric vitrectomy. Now I call somebody who is a giant person, in the vitrectomy as far as the Vitreoretinal Society is concerned in India. I welcome Dr. Lalit Verma, sir, to please share his experience on giant retinal tears, sir.
Thank you so much, and greetings to all the national and the international faculty. I'm very happy to be part of this Reticon meeting, and congratulate these two aces, Atul and Ashwin, for drafting a very, very nice program, and I have been hearing for last hour or so. Fantastic program, great faculty, all the topics very well covered. So my job is here to cover GRT. Part of it has already been covered. So I'll be presenting 3 short cases. You see in the beginning only in this patient, I have put chandelier illumination. You see this patient had more than 180-degree GRT. So after you take care of the vitreous, so very difficult sometimes to, elevate this flap. So here, because I wanted a plane, So use the soft tip needle in one hand, in the left hand, and in the right hand, the PFCL cannula, and so as to find this plane. So this is very, very important because you can't inject PFCL blindly like this. So with the help of this bimanual technique, we could, elevate and then inject. And after that, complete the entire vitrectomy. Diathermy is useful to mark that area of the break and then do a direct exchange with silicone oil. And very important to do multiple rows of laser in all patients of giant retinal tear. No encircling band was used in this patient at all. This is the end of surgery. This was another patient who had a cataract also. So you do a lensectomy because you don't want any hindrance during surgery. And as was being told, you see, very important to clear the vitreous anterior to the break. So here we have an inferior tear, large tear, and I am cutting the vitreous anterior to the break and also will take care of the anterior flap of the giant tear. So this is being demonstrated here, that vitreous-based shaving, and also sacrifice this anterior flap also. And then you have various membranes, subretinal or preretinal. So this is showing the usage of forceps to take away this pigmented kind of thick band, which is subretinal, and which will avoid the settling of the retina. And sometimes you can have, hand rollover technique also to take this membrane, usage of 2 forceps. And after this, mark with the help of diathermy, both the anterior as well as posterior sometimes, because I will sacrifice the anterior flap after marking, like is being shown here. Sacrifice the anterior flap, and after this has been done, then fill up the cavity with PFCL right up to the iris surface. You see, you have to be liberal in using the PFCL in this patient. And then under PFCL, I would do 3-4 rows of laser, not only around the break, but all around. And then since the patient is aphakic now, I did an endozyridotomy, because the next step would be a direct exchange of silicone oil with PFCL, as is being shown here. And this was the last patient. Here again, IOL had already been put by somebody, and we had a nearly 360 giant retinal tear. Here, first attention is always to the vitreous. Retina is already folded. And after you find a plane, then you inject a little bit of PFCL, and then you can iron the retina or massage the retina so as to follow the contour of the globe, as is being shown. Then cut rest of the vitreous and put more PFCL. And gradually, as you peel the membranes, put more PFCL, and the retina gets conforming to the curve of the globe. And more PFCL till the iris brim. And then under PFCL, after the retina is flattened, you put multiple rows of laser round 360 degrees in all these patients. Cryo, I have stopped using in all these patients, although this demonstrates a small cryo application here. And then this is the silicone oil being injected, direct exchange, and last bubble of PFCL coming up in this patient. So these were the couple of videos. This is one of the pre and post-operative, a highly myopic patient who had more than 180 degree, and post-operative after silicone oil removal gained 6/24 vision. So hats off to Stanley Chang, the discovery of PFCL. Now GRT has become a relatively simpler surgery. We do a total vitrectomy base dissection, try to mobilize the retina and remove all the membranes, pre-retinal as well as subretinal. PFCL fillages up to the iris plane or sometimes up to the cannula also, and do endo laser multiple rows, and direct silicone oil and PFCL exchange helps in all these patients of GRT. Thank you very much for your kind attention.
Thank you, sir. It's always a pleasure listening to you. Now I'll call Dr. Shinu M. Hariprasad, our international faculty. He is going to talk on something new on neovascular and AMD therapy update. Welcome,
Thank
sir.
you so much for the kind introduction, and I agree wholeheartedly with Dr. Verma. The quality of the lectures and the organization is second to none. It's such a pleasure to be with so many friends on the call, and really learn a lot from all these lectures from around the world. With this second lecture, I want to present our experience with brolucizumab, and it's a new anti-VEGF agent that I understand has just been released in India. And we're going to talk about a subset of the Hawk and Harrier studies, really looking at the fluid status of patients who are treated with this new agent. Now, undoubtedly, reducing the treatment burden of injections while maintaining long-term efficacy is considered to be an opportunity for improvement in the management of neovascular AMD. Retinal fluid and central subfield thickness assessed by OCT are key anatomical markers used by retina specialists to determine injection frequency in clinical practice. In this analysis, we report a post-hoc exploratory evaluation of the anatomic outcomes of brolucizumab versus aflibercept in the treatment of neovascular AMD from 2 phase 3 randomized multi-center FDA registration trials called Hawk and Harrier. And, it's a very sophisticated group, but you can see the image on the right showing the different layers of fluid that we're worried about when we see these patients afflicted with wet macular degeneration, the intraretinal fluid, subretinal fluid, and sub-RPE fluid. So without a doubt, fluid is a hallmark of neovascular AMD disease activity. And we typically, characterize disease activity based on 3 parameters: a loss of about 5 letters in vision, evidence of new macular hemorrhage, but the presence of fluid on the OCT scan. And fluid on any space in the OCT is pathologic, in my opinion, and requires anti-VEGF therapy. And early detection and treatment of disease activity in neovascular AMD can optimize visual outcomes in patients. The Hawk and Harrier study design really was quite simple. Brolucizumab versus aflibercept. In the matched phase of the study, we call it, 3 monthly loading doses of either brolucizumab or aflibercept based on what group the patient was randomized to. Now, patients who received brolucizumab went on to an every 12-week dosing regimen. However, there were several points in the study where patients underwent a disease activity assessment, things based on OCT, visual acuity. And if there indeed was disease activity, the patient was dropped down from an every 12-week dosing regimen to a every 8-week dosing regimen and was kept on that dosing regimen till the end of the study and was not brought back to a 12-week dosing regimen. Aflibercept was dosed every 8 weeks after the initial loading doses per the FDA label. Brolucizumab was found to be non-inferior to aflibercept in mean vision from week 48 and week 96, the primary endpoint and the end of the study. So now let's focus on the anatomic outcomes in Hawk and Harrier. So in our post-hoc analysis, we focused on the proportion of patients with simultaneous absence of intraretinal fluid, subretinal fluid, and sub-RPE fluid at week 16, 48, and 96. Secondly, we looked at sustained dryness up to week 96, specifically the absence of intraretinal fluid and subretinal fluid for greater than 2 and greater than 3 consecutive visits. And then we also looked at the sustained presence of intraretinal fluid and or subretinal fluid until week 96. These patients specifically were never fluid-free at any visit in the study. Now, when we look at these graphs, what we find is that a greater proportion of brolucizumab patients had complete fluid resolution, specifically absence of subretinal fluid, intraretinal fluid, and sub-RPE fluid at week 16, 48, and 96. Throughout the rest of the slides, gray is aflibercept, light blue is the 3 milligram dose of brolucizumab, and dark blue is a 6 milligram dose of brolucizumab. And let's pay attention to the dark blue because that ultimately was the FDA-approved dose, which is 6 milligrams. But you can see across the board, a greater proportion of patients had fluid-free status and fluid resolution. Likewise, more brolucizumab patients had greater than 2 consecutive fluid-free visits, which was simultaneous absence of intraretinal fluid and subretinal fluids up to week 96. Furthermore, more brolucizumab patients had greater than 3 consecutive fluid-free visits up to week 96. But very interestingly, fewer brolucizumab patients had sustained presence of intraretinal fluid and or subretinal fluid and were never fluid-free at all visits at week 48 and week 96. So overall, the drying effect of brolucizumab is clearly superior to that of aflibercept. Now, to demonstrate the power of the drying effect of this drug, I want to share a brolucizumab case with you. This is a 59-year-old Caucasian female where we did an early switch to brolucizumab. I had started her on Eylea or aflibercept about, I think, January of this year. And then what happened was she received 2 Eylea injections every 4 to 5 weeks apart, and she still had persistent subretinal fluid, a small PED. And what we did was I told her, it was the end of March, and I told her that the COVID-19 virus is probably going to cause disruption to our clinics and our ability to see her sooner. So why don't we use a drug like Beovu, brolucizumab, which can have a better drying effect, because I didn't know the next time I would be able to see her in clinic. So at the time, after 2 aflibercept injections, her vision was 20/50, and we gave her a brolucizumab injection at this visit. And then you can see after 5 single weeks, after 1 single brolucizumab injection, look at the improvement in the restoration of the foveal contour. The PED is gone, subretinal fluid is resolved, and her vision improved 1 line from 20/50 to 20/40 vision. And you can see side by side, after 1 single Beovu injection or brolucizumab, you can see the improvement in foveal contour. So in conclusion, in this post-hoc analysis, more patients achieved fluid resolution with brolucizumab during both the matched and maintenance phases up to week 96. More patients demonstrated sustained dryness for greater than 2 and greater than 3 consecutive visits to week 96 with brolucizumab. Fewer brolucizumab patients had sustained presence of intraretinal fluid and or subretinal fluids. Specifically, these patients were never fluid-free up to week 96. And lastly, we conclude that the results show that brolucizumab is better at drying the retina than aflibercept. So thank you very much for your attention again, and really it's such a privilege to be part of this esteemed group. And thanks again to the organizing committee for including me in this meeting.
Excellent presentation, Dr. Sinu. Really enjoyed this talk. And next, I think we have Pritam Samant coming up to tell us about, again, macular surgery. Pritam, over to you.
Is my screen visible, sir?
Yeah.
Yeah, okay.
So
at the outset, I would like to give my compliments to Dr. Amar Agarwal, Dr. Ashwin, Dr. Atul for such a fantastic meeting. I think I have not missed a single edition of Reticon. And I must say that pandemic or no pandemic, Reticon just keeps getting bigger and better. Also, my respects to a lot of my seniors and teachers here, Dr. Natarajan, Dr. Mahesh, Dr. Lalit sir, Dr. Mohan Rajan, I can see. All my respects to the esteemed faculty. My focus of my talk is going to be the difference between how macular hole surgery, the technique has evolved over the couple of years. So I have chosen specifically 2 videos at a gap of 5 years. The first one is 5 years ago, where we used to follow, can you see the video running? So this was the conventional macular hole surgery where, the aim was to get the entire ILM out. So you can see its ILM has been stained by brilliant blue already, and I'm using a vitreous forceps to peel the ILM. It was essentially a maculorhexis. The trick here is to grasp the ILM every 2 clock hours rather than just peeling it off, because so as you don't avoid any injury, tangential injury to the retina. And the aim was not to leave back any ILM tag around the macular hole. So these were some of the concepts we followed. As you can see here, I'm peeling it right up to the arcade. You can see some of the triamcinolone still, on the ILM, which was used to induce the posterior vitreous detachment. And on horizontally, the ILM was peeled right up to the temporal edge of the disc and equal distance on the outside. And this technique, and this was followed obviously by gas injection and prone positioning. And this technique did give very good results. And then this was what was done previously. And now what I have shifted in most of my cases, and you can see the edge of the peeled ILM over here. But now what I've done, what we do now is where we use the ILM, the reverse ILM flap technique, where the ILM is actually used to plug the macular hole and to achieve a better closure rate. So again, you do a vitrectomy. Now here I would just like to pause the video and make a quick mention. I think it deserves mention here. You know, a lot of I used to use Constellation in the past. I have both Constellation and you know, the Galaxy robot vitrectomy machine, and this machine does deserve a special mention here because I have shifted a lot of my cases I do on the robot machine. This particular machine has 3 vitrectomy modes to begin with, so that is an advantage. You know, you can see this cutter here. This is a 10,000 cuts per minute vitrectomy cutter, and they are soon going to come out with the bi-blade cutter, which will effectively give 20,000 cuts per minute. You know, their dual LED lights is also very important, especially when you're using the chandelier for bimanual surgeries. And their positive pressure fluidics are as comparable to any of the top line vitrectomy machines. In fact, you know, the fully loaded robot also comes with an inbuilt 532 nanometer green endo laser, as well as a fully video recording system. So I think this is just, they have really done a good job with their machine. So in the ILM technique, you essentially go with the same steps where you put the triamcinolone to stain the vitreous, then you induce the posterior vitreous detachment, as you can see over here, with suction from the cutter, followed by a good vitrectomy. Then the staining of the ILM with the OcuBlue Plus. Most of the people use a diamond knife to make this initial flap, but I've started using a 26 number needle to do it. I find it just more precise and useful. And now what you're doing here is, instead of removing the entire ILM, you're peeling it centripetally towards the edge of the macular hole, and you leave these flaps. You leave these flaps hinging, especially on the temporal side, crescentic temporal side on the edge of the macular hole. And while you've done that, the outer part of the ILM you peel routinely as you're peeling it, like I said, from arcade to arcade and horizontally from the edge of the optic disc to an equidistant part. You can see this final gap left behind, which I'm severing from the portion near the macular hole, and the rest of the ILM being peeled. And then this particular ILM is used as a plug, and it is gently inserted into the depth of the macular hole. Of course, one has to be careful here not to injure the retinal pigment epithelium there. And this particular plug, it sits pretty well into the depth of the macular hole. And then this is followed by fluid air exchange and gas injection. Now, you know, the question is, how has this really made a difference in the success of the macular hole surgeries? Now, the way I look at it, my indications, although I have been doing it now for most of the cases, I think where it works the best is where the macular holes are really large and, you know, chronic macular holes. These are the places where it works really well, and it essentially gives a good anatomical result. And a good anatomical result means would translate into a good functional result. So that is how it indirectly helps, you know, to improve your success of macular hole surgery. So that's the end of my presentation. I thank again the organizers. Thank you.
Great, great talk, Preetham. The only issue is about the plug-in. You see, everything else I do, but I don't want to injure the RPE. You said you should be careful, and there's no parameter, you know, how much to, you know, that is the only issue I differ. Everything else is perfectly okay. And I know results are very great. And even after 14 years of one of my patients, she improved. But it's the same technique what you showed. Congratulations. Wonderful job done. Next, we have Dr. Jyotsna to tell us about VR interface disorders. Dr. Jyotsna is there?
Yes, sir.
Please.
Is my screen visible?
Yes, yes. Very nice.
Good evening, everybody. My talk this evening is on vitreoretinal interface disorders. The vitreoretinal interface is the median plane of the posterior vitreous cortex and the inner surface of the internal limiting membrane. Now, there are two reasons for this term vitreoretinal adhesion. One is the fact that the collagen fibrils are inserted perpendicularly in the vitreous cortex, and two is the presence of this blue-like extracellular matrix. We know that PVD has two processes. One is gel liquefaction and two is separation of the vitreous from the retina due to weakening of this glue. Now, if these two processes happen in tandem, then it gives rise to an innocuous PVD. But if the gel liquefies sooner and the vitreous continues to be adherent, then we have an anomalous PVD or a vitreoskisis. So if this traction is persistent at the vitreous base, then it gives rise to retinal tears, retinal detachment, and vitreous hemorrhage. But if it is persistent over the posterior pole, then it gives rise to a spectrum of disorders, which is what we will be discussing today. So the first of this is vitreomacular adhesion, which is defined as a partial detachment of the vitreous in the perifoveal area, but it continues to be adherent within a 3 mm radius of the fovea, and there are no changes in the foveal contour or retinal morphology. These patients are asymptomatic and only require serial OCT follow-ups. If there is a distortion of the foveal surface with intraretinal structural changes and elevation of the fovea above the RPE, we classify it as vitreomacular traction, which we divide into focal and broad, and based on morphology as V and J shaped. Now, some of these patients may have a concurrent epiretinal membrane, where the membrane proliferates both on the retinal surface and onto the detached posterior hyaloid. So there is greater traction in these patients with an increased incidence of intraretinal cysts, outer layer discontinuities, and a poorer visual function. Some of these patients may also have focal traction with the formation of a foveal pseudocyst. This may sometimes resolve spontaneously with release of traction. Patients who complain of metamorphopsia do well with vitrectomy and a fovea-sparing ILM peel. An earlier intervention is recommended if the fellow eye has had a full thickness macular hole. Predictors of better visual outcome include focal VMT, shorter symptom duration, a younger age group, greater outer foveal thickness, and an intact outer retinal layers. Pharmacological vitriolysis can be considered in patients who have focal VMT as long as there is no ERM and they are non-myopes. The third entity is full thickness macular hole, which we classify based on the size of the hole, the presence and absence of vitreomacular traction, and based on the etiology. If vitreoskisis has occurred, then there could be a concurrent epiretinal membrane. If there's been a posterior vitreoskisis, then we see these thin hypocellular membranes, which are best noted intraoperatively after staining. These are difficult to grasp, but they come off contiguous with the ILM. Sometimes you may also see an epiretinal proliferation similar to what has been described in lamellar macular holes. These are much thicker, associated with intraretinal splitting, and may extend onto the middle surface, middle layers of the retina, and these are particularly tenacious to the edges of the macular hole. With regard to the surgical aspects, I think it's already been covered beautifully, but I'll just add 2 points. Predictors of better visual outcome include smaller holes, greater height of the hole, presence of VMT, a better pre-op vision, and a shorter symptom duration. Pharmacological vitriolysis is successful in small and medium holes with concurrent vitreomacular traction. The fourth entity is lamellar macular holes, which is of 2 types, and I think it's been covered in great detail with regard to the surgical aspects also by Dr. Kshitij. So I think in the interest of time, I'll skip this. The fifth entity is epiretinal membrane. We know that if there has been an anterior vitreoskisis, the hyelocytes remain on the retina and they stimulate the migration of monocytes and glial cells. Proliferation results in very thick hypercellular membranes. Now, as these membranes contract, they alter the retinal morphology. What we now know is that the inner retinal layer changes can cause visual distortion even before the disruption of the ELM and the EZ. One such prognostic biomarker with respect to the inner retinal layers is ectopia of the inner foveal layers, which is defined as the presence of a continuous hypo or hyper-reflective band extending from the inner nuclear and inner plexiform layers across the foveal region. In a study by Gavetto et al., they have classified the ERM into 4 stages based on the OCT findings. Stage 1 is when the foveal depression is preserved. Stage 2 is when it's lost. Stage 3 is when continuous EIFL cover the whole floor of the foveal floor, but the retinal layers are still well defined. And in stage 4, there's a complete disorganization and all the retinal layers are disrupted. The importance of EIFL is that it correlates with a lower pre-op visual acuity and less likelihood of restoration of normal morphology after vitrectomy. And poorer visual and anatomical outcomes are associated with increasing stages of the ERM and EIFL persisted even after vitrectomy in most eyes of stage 3 and stage 4 ERM, making a case for earlier intervention in ERM, perhaps in stage 2 patients who are symptomatic or have a documented recent visual loss and are showing morphological progression, and in stage 3 before the EIFL becomes continuous. The last entity is macular pseudohole, which is caused by a contraction of the epiretinal membrane, leading to invagination of the foveal edges, a verticalization of the foveal contour, but there's a normal central foveal thickness, and these patients generally remain stable with good vision. A subset of patients with macular pseudohole may actually show cleavage of the edges like this. This resembles a tractional lamellar macular hole, and these patients may require closer follow-ups. So to just summarize, anomalous PVD is the unifying pathogenic mechanism for vitreoretinal interface disorders. Patients complain of metamorphopsia and decreased vision. Biomicroscopy may be very subtle, like an absent foveal reflex and wrinkling of the retinal surface, or it may be more obvious circumscribed red lesion in the context of macular holes. The OCT is always diagnostic in defining the pathoanatomy, identifying the various vitreous adhesions, measuring the retinal defects, the size of the defects, presence and cellularity of the epiretinal membranes. It's a useful tool to monitor progress and to predict the surgical prognosis. Asymptomatic patients can be just observed with serial follow-ups, but vitrectomy with various ILM peeling techniques, which have already been discussed, is the mainstay of treatment. Pharmacological visualizers can be considered in a subset of patients with small to medium macular holes and vitreomacular traction. These are my references, and thank you all for a patient hearing.
Thank you, Dr. Josna. You have covered a lot of topics in these 5 minutes. Now we come to the last topic of this session. I welcome Dr. Sondri. She's going to speak on advanced vision analyzer for neuro-ophthalmology.
Thank you so much, Gaurav. First of all, I would like to thank Dr. Anush, Dr. Ashwin, and Dr. Atul for giving me the opportunity. Today, I'm going to be talking on AVA. So when you look at the picture, people must be wondering what it is. Is it a virtual reality game? No, it is not. It is an advanced vision analyzer, which is an autoperimetry, which has a head-mounted device, a patient response button, and a tab. We are in a smart era. We want everything to be smart. We want smart televisions. We want smart mobile phones. We want smart watches. Why not a smart autoperimetry? That's what we have. What we have is the advanced vision analyzer, which is a smart perimetry device for visual field threshold measurements. So why smart? It has got a smart package, which is compact and portable, where you can actually put the head-mounted device, the patient response button, and the tab inside a compact portable bag, and you can take it anywhere. In this COVID times, actually, patients are afraid of coming and visiting the hospital. And autoperimetry, which has to be done, is not being done. Actually, the patient wishes, the patient can do the autoperimetry sitting at the comfort of their home safely. So this is so very portable that it can reach everybody's home. It has got a smart technology, smart design, patient-friendly, can be used anywhere. And smart investment, very friendly to the pocket. And most important, it's FDA approved. So you can set up the test in a few clicks. It has got a broad gaze monitoring system. Monitor and control test over a wireless connection can be done. Advanced infrared tracking technology to monitor and minimize the fixation loss. And it can send report through email or print wirelessly. So when it comes to neuro-ophthalmology, the most important thing is basically you look at the vision, color vision, extraocular movements, pupil, fundus, and perimetry. So these are the main important things. So if you're talking about vision, color vision, pupil, extraocular movements, and fundus, everything can be done at the bedside. So basically, confrontation is one thing which you can do at the bedside. But when you have the perimetry, why not do it? Earlier, the patient used to come to the hospital to get the perimetry done. Now you have the freedom of taking the perimetry to the patient. So assume that the patient is bedridden. The patient is not able to move. They've undergone a surgery, or in a case of a post-trauma, where the patient is not able to come to the hospital, the machine can go to the hospital, wherever the patient is admitted, and it can do the test. And it's got a lot of freedom for the patients. Basically, in a HFA, you have to put the chin rest and the forehead rest. So basically, the patient has to put it like that and have to do the test. Basically, in patients where they are wheelchair bound or very short patients, obese patients, where they have neck stiffness, as in case of ankylosing spondylosis, all these patients, they'll find it difficult to put the chin rest and the head rest. So thus, for those patients, this AVA is a boom. Basically, they can do the test in a semi-reclined position. They can do wherever they want to. They can sit in a sofa and do it. So it's very, very useful. And the headset device, which has got the test going through, basically, it will be testing each eye, and the other eye need not be patched. So when the other eye is not patched, even in children, it is very, very useful to do the test. And not only that, it has attachable magnetic trial frame and lenses, which can be fixed in the head-mounted device itself, so that the patients are very comfortably doing the test. So, and we are so much used to the HFA reports. So from college days, we have been always seeing the HFA reports. So the report of AVA is something similar to the HFA. So reading the report becomes easier. So 30-2 threshold field identify defects very clearly and accurately. Here you have a superior quadrantenopia, which you can very well make out looking at the field. So yesterday I had a patient, 50-year-old, who had visited me with the complaining of defective vision, had a recent history of stroke. So I wanted to do the visual fields. I said, get an AVA done. So they did the AVA. Since I had the presentation, I said, get a HFA done so that I can show the comparison between the AVA and the HFA. This is what you get. It's a right-sided homonymous hemianopia. On the right side, you have the AVA, and the left side, you have the HFA for the right eye as well as the left eye. You can see the results are very much comparable. Close to the performance comparison through multiple site prospective studies covering 800 subjects has been done, and the visual outcomes of AVA were statistically equivalent. So the key features are basically the AVA has got a foveal threshold testing. It has got a gaze monitoring. The test patterns which are available are 24-2 and the 30-2, and test strategies including screening, full threshold, ELISAR Zest and ELISAR Fast is available. 10-2 is under development. It's one of the newer technology and very patient friendly, can be used at any place. You don't need a separate dark room for this, and patient can do it wherever they want, in a refraction room, in your clinic, in the waiting area, wherever the patient wants can sit and do the test. It is very friendly to the patient and very friendly for the doctors as well. Thank you so much.
Thank you, Jyotsna.
And Dr. Saundari, sir.
Sorry, thank you, Saundari. I was reading.
Okay, sir.
Jyotsna, yeah. Thank you, Saundari, for this introduction of AVA. In fact, in COVID, everybody, all glaucoma people are saying perimetry should be deferred for months and months. I think this should be told to everybody, all the glaucoma people also, that you can, this is a portable device available and FDA approved. Really wonderful 8 talks. I think 8 talks in dot time. I think Atul and Ashwin must be very happy that all of us have fared in time. Really enjoyed. Atul, thanks a lot.
Yeah, thank you, sir. Thank you. Ashwin?
Yeah. So, after such a great session, it honestly takes me a little bit aback that why didn't I do Retina? But anyways, I wanted to use this time to actually just introduce a new program that we are starting off from the 13th to the 16th. It's our old Kalpavriksha. This is our 14th edition of Kalpavriksha. We are launching it now. It's going to go on 13th to 16th of August. Again, you can go to the website to register for it free. It's a PG training course. I think we've got people from pretty much all the institutes across India. We wanted to launch it here to tell everybody to, spread the word as much as you can. Kalpavriksha is on the way. We're ready to go. Program directors, organizing secretary is going to be Dr. Namrata Sharma, Dr. Soundri, and Dr. Divya Ashok. So welcome, and I hope to see you guys there, viewers. Thank you. Atul, all back to you.
Okay, I think some. 1 second, I think some advertisement is there. Yeah. Just 1 second. Ravi? Yes, sir.
Okay, yes. Where is this? Where is
One second. Atul, you can start the next session, sir. No.
Where is me?
Don't worry about this. Let's move on. Guys, can we move on? Leave this. Avoid this. Atul, you can move on with retina bit. Stop share.
1 second. I think it's still your share. Your screen is shared. This one, retina bit finder. Stop sharing. In front of all the stalwarts, I am going to present how to make VR surgery easy. First is Osdex in the AC. Osdex has come because of the zonulodialysis. Just make 2.5 mm incision. Place the implant in the line of incision with the help of faucet. Inject low molecular weight viscoelastic. Press the lower lip of the incision, remove the implant. And you can see it is very fragile. The second is oil in the antechamber. In the case of faking and pseudophakic eye, in the early post-operative period, if the oil is in the AC, make 2 mm incision at the limbus, inject the low molecular weight viscoelastic, press the lower lip of the incision, take out the full oil, and just put one suture, close the eye. PVD induction, use triamcinolone to stain the vitreous and use high magnifying lens. Place the cutter near the disc edge. With the sweeping motion, hook the posterior highlight with the high section. Induce the PVD in the posterior anterior direction. SRF drainage without PFCL and posterior retinotomy. Tilt the head towards the primary break and make it most dependent part of the eye. Do the maximum SRF drainage with the help of the gravity. In this case, the break is at the 12 o'clock position, so just chin up and drain the fluid. Subretinal oil removal in the case of posterior subretinal PVR, which has gone posteriorly. Inject the saline in the subretinal space. Place the retinotomy at the higher level by adjusting the head position. Push the oil by silicone tip towards the retinotomy side. Remove the silicone tip and aspirate the oil by the active suction. Subretinal band removal in the case of dense PVR. Place the chandelier, and it should not be obliquely, it should be direct entry. Hold the band from one faucet and pull from the other faucet. By this technique, you will not lose the band behind the retina, and you can take out the full band in toto from a very small retinotomy. Dosa technique. You can learn the temporal flap from any South Indian restaurant very easily. Temporal flap with chromoviscotempo technique. In this case, 180-degree flap I have used. Create the initial part of the flap with the finish loop. You can adjust the length of the finish loop. This is a wonderful instrument. Do it very gently. Don't tear the flap. Start peeling from one side, extend to the other side. Be very gentle. Place the flap over the hole and support it with the help of the color visco, followed by the fluid air exchange. Lamella macular hole. Surgeon has given the hypothesis that the vision loss in the tractional lamella macular hole is because of the synaptic breakage at the outer plexiform layer. So remove the epiretinal membrane. Put the ILM transplantation. ILM flap will lead to the restoration of the fovea and the synapses and increase in the vision. Creation of the ILM flap, in this case, by temporal area and stabilized by the color visco. At the end of the fluid air exchange, rolled over flap was correctly placed over the hole by color viscosuction assisted ILM flap transplantation technique. It is very easy to maneuver the flap under the visco. Epiretinal membrane removal. Hold the edge with the end grasping forceps. Hold the membrane very close to the macular surface to prevent its tearing. If abnormal adhesions are present, regrasp and strip towards the area of adhesion from the another direction. By this, you can take out the full ERM in toto. Diabetic membrane removal. Use bimanual surgery. Place the chandelier directly, not obliquely. Don't pull too much from the non-dominant hand. Find plane of dissection, inside out, outside in. Any technique you can choose. And with patient, give very small snips. At the end of the surgery, you can take out the membrane in one piece. Always remember, don't make the tractional artery into the combined artery. Thank you very much. So you can see. Hello?
Yes.
Hello? Yes. So we can start the question answer session. The panelist in this session is Dr. Ram Millet, Dr. Ramsey, Dr. Zofia, Dr. Barbara, Dr. Pramod Bendesa, and Dr. Sunita. Hello?
Yeah.
Hi.
We can start the question answer session for the 2 minutes, sir.
Okay.
Hello. Hi.
Hello.
Yeah, Dr. Ramsey, we can start the session.
Yeah, sure, we can start.
No, for 2 minutes, the question and answer session with me, sir.
Okay, we are ready.
The discussion part is open, sir.
Atul, can I ask a question?
Yeah.
So you always perform wonderful temporal flaps. And I think you're the master of it. They look great. Usually they break up very easily. So maybe you have some tips to suggest that the whole flap in one place. And also, I would like you to give us a tip on how to avoid a dislocation. You remember I asked you that, and I think it's good for everybody.
I do the fluid air exchange for the 2 to 5 minutes after the surgery. So the fluid which is coming from the ciliary body will not dislocate the flap at the end of the surgery. And I tell the patient directly from OT table, directly I shift the patient to the outside room. At least for 3 to 4 hours, the patient is in the outside room in the face down position. So
we always make a face down, but do you think that the size and the shape of the flap makes a difference to hold the flap in place? I think it's crucial.
Yeah, if you'll go by mathematics and the surface tension, I have taken out that if you'll go with the 2 disc diameter, double the size of the disc, the surface tension is very good between the 2 layers of the ILM. And it will not move from the one side to the other side.
So in order to keep,
Maybe I can say something about this. In my practice, I use PFCL bubble to keep the flap in a single layer without wrinkling, without folding, because I really pay attention to keep the flap as a single layer after surgery. Therefore, I use a small piece of PFCL bubble after the peeling, and after the folding the ILM, I inject a small piece of PFCL bubble and keep that for a few minutes during vitreous space cleaning or the checking for retinal tear, and then remove that after fluid air exchange. First remove all the fluid, then remove the PFCL bubble, and it really helps to keep the flap as a smooth layer. This is my practice tips and my practice.
Thank you. And Atul, do you think that designing the edges of the flap with the, sorry, I forgot the name, with the finesse loop makes a difference to have it in one piece instead of breaking the ILM in small pieces?
The best part of the finish loop is you can create a smooth flap without tearing up the ILM in the many pieces. You can easily create, and you can adjust the length of the flap also. And the adjustment of the flap in the finish loop length will give to the adjustment of the tensile strength of the finish loop. And usually it lasts for 4 or 5 cases. It will not go in 1 or 2 cases. So it's a very good instrument.
Yeah. Ramsey, how do you do it? Do you design the
usually
flap or
I
just
do not. Yeah, I do not like a finesse loop because in my head lens I feel that it makes some damage with pressure during using this instrument. I usually use ultra peel forceps from Dork. Is 27 gauge ultra peel forceps. It's very large tip, and it's not create any tearings and not damage during peeling. So this is another way, and I just use forceps.
I have no experience with that instrument. Any other questions? So now we can move to Dr. Ramsey. He's from Turkey, and he will talk about the management of the complex retinal detachment.
Okay, so thank you, dear colleague. Good evening. Before start my talk, I would like to thank Dr. Atul and Dr. Ashwin for their kind invitation. It's a pleasure for me to be a member of this faculty of this great meeting. So in my talk, I will speak about the treatment of complex retinal detachment. I have no financial disclosure. As you know, PVR is one of the most challenging problems in retinal detachment surgery. And in the primary retinal detachment case, we usually observe posterior PVR, but however, in recurrent retinal detachment, mostly anterior PVR occurs in the vitreous space. And the treatment of anterior PVR is much more difficult and has lower chance of success rate comparing to posterior PVR. Therefore, a method that will provide a high success rate should be preferred in primary surgery. The basic principle for surgery is remove of all vitreous as much as possible, release of all retinal traction, and close of all retinal tears. So therefore, membranectomy is one of the most important steps in these complex cases, and the membrane on the vitreous space should be cleaned with grid patients, and better membrane cleaning, the less need of retinectomy, and the less retinectomy means the less risk of chronic hypertony. So in my practice, I use bimanual working during membrane peeling. Also, I use adjuvant agents such as triamcinolone dyes and perfluorocarbon liquids during the membrane peeling. This is 10-year-old boy referred to my department after recurrent retinal detachment. The primary surgery was vitrectomy and silicone oil tamponade. I use treatment blue usually to increase the visibility of this membrane, and then use bimanually peel all the membrane. In this patient, I attached retina without needing any retinectomy or scleral buckle, then applied 360-degree laser and silicone oil, and 2 months later, I removed the silicone oil. As you see, the retina is perfectly attached and there is no PVR. Also, implant and scleral fixation IOL in this traumatic aneurysmic eye, and the vision improved to 0.6 after surgery. Another patient with severe PVR in combined surgery, usually I do all my work in the anterior segment, including IOL implantation, then go to posterior pole. As you see, this is funnel-shaped retinal detachment. Even in such eyes, we can manage to reattach the retina with only peeling the membrane. Therefore, membranectomy is a very important step. And in this patient, we did not need any retinectomy and also no scleral buckle. And after silicone oil removal, 2 months after surgery, you see retina is completely attached and the vision improved 0.1. However, this is not possible in all cases, especially contraction, fibrosis, and atrophy of intrinsic retinal elements may cause retinal foreshortening. And retinal shortening occurs particularly in the vitreous space and prevent retinal reattachment unless retinectomy or scleral buckle is performed. Both technique, buckle and retinectomy, can be achieved good anatomic results. Which one is better? So this is a controversial point. I think the key point is that the surgeon should apply the best technique in his own experience. In my practice, I usually prefer retinectomy instead of buckle, and I rarely use circumferential scleral buckle in complex cases. And also I observed that for most retinal detachments, scleral buckle is unnecessarily overrated, and it may not be necessary when tractions are adequately relieved with retinectomy. So there are several studies in study which show that good anatomic results after retinectomy in these complex cases. And for example, this patient has inferior quadrant recurrent retinal detachment, and the primary surgery was vitrectomy, scleral buckle, and gas tamponade. So there's no apparent membrane, or so there's no tear, but the retina is not detached because of the shortening of the retina. In such a we have to do retinectomy, and in this patient we apply 180-degree inferior retinectomy. I usually prefer selective diathermy for this patient, and then I do not peel membrane, just attach the retina, do laser, both anterior and posterior flap of the retina, then fluid exchange and long-acting gas tamponade. This is 4 weeks after surgery. You can see completely attached retina in the inferior part of the retina. Still, the gas is on the superior part. Another patient with recurrent retinal detachment, posterior PVR, and also anterior PVR. The primary surgery in this patient was vitrectomy and scleral buckle surgery, combined surgery. And even in this patient, there was no apparent retinal membranes, and we applied 200-degree retinectomy. And in such patient, I do not remove anterior retinal flap as a mandate of giant retinal tear, because if there's scleral buckle, I keep the anterior retinal flap in place and to prevent chronic hypotony, and 360-degree retinectomy, and 4 weeks after surgery, retina is completely attached. Another difficult case, this is very severe tractions, proliferations, and multiple retinal tears. Even though we peel all the membrane, it was not possible to attach the retina because of shortening of the retina, and therefore we applied 360-degree retinectomy and laser. And this is 4 months after silicone oil removal. Retina is completely attached, and vision, we achieve 0.16 vision in this one eye patient. So in summary, we should pay attention to do the right operation. Radical vitreous anterior base dissection is very important. Lancectomy is when necessary. Good membranectomy, retinectomy, or scleral buckle depends on surgeon's preference. So also we should do the operation right. We should match the grade of detachment to the experienced surgeon. This is very important. Timing of our surgery also we can arrange according to the availability of a vitreoretinal surgeon. We should prefer regular operating day instead of emergency condition, and optimization of surgery is also another important topics. In summary, the membranectomy should be performed with great patience in such cases, and retinectomy helps us to reattach the retina in many complex retinal detachment, and scleral buckle may not always be necessary when the traction on the retina can be relieved adequately with retinal retinectomy. However, scleral buckle might be preferred for selected cases such as young phakic eyes, myopic eyes, or hereditary vitreoretinal degeneration cases with severe vitreous-based adhesion. Thank you for your attention.
Thank you, Dr. Ramsey, for your excellent talk. And I would like to ask one question. In the case of the severe posterior PVR, whether you like to go for the ILM peeling or not?
Yes, if there is severe PVR, I always peel ILM in this patient also to prevent macular problem, epiretinal membrane, and others. But not in fresh detachment, but in complex cases, I regularly peel ILM.
And you do under the PFCL?
Yeah, in attach, but I under the PFCL, usually under the PFCL, sometimes without PFCL, but mainly under the PFCL.
Okay.
I have a question for you, Ramsey.
Sure.
So if you have a recurrence of membranes of PVR in the periphery, do you peel the PVR without the retinectomy? Let's say it is the second or third surgery. So if you have epiretinal membrane, do you always peel without retinectomy, or do you combine? Because sometimes I feel that I postpone the retinectomy choice when there is no more PVR and just the retina is so stiff that it doesn't flatten without cutting.
It's not easy to decide in that point, Barbara, but if I feel that retina is released enough under PFCL bubble, so I do not prefer to do retinectomy. If it is not, if there is some stretching still after the peeling of membrane, I do not hesitate to do retinectomy. I prefer retinectomy to prevent recurrence again in that area.
Because I have this thought I would like to discuss with you, that if we have membranes, it means we have phlogosis, we have inflammation going on still. So if we are traumatic and induce a cut, maybe we will stimulate new membranes to come back. Instead, if we don't have any membranes and just a stiff retina, it's the time to cut because the eye is quiet, and that's the last vitrectomy, and then we will be comfortable in removing the oil, and that's it.
Exactly, but in such patients, usually, as you know, we do not prefer retinectomy. We usually prefer just retinotomy and to release the retinal shortening. That's all. So I do not think that retinotomy increased the inflammation like retinectomy. And if we manage to hemostasis also bleeding, prevent the bleeding with diathermy also. So this is not really easy to answer this. It depends from patient to patients, but I usually
it's a feeling that comes after many highs and failures. That
better to discuss this in an example of case from case to case. The answer will be changed.
Actually, I have tried in times. I don't know if I still have time to talk at all. That trying to give a scheme on how to treat these very difficult patients as well. I think PVR is a disease that lasts at least 1 year, 1.5 years, and we have to tell the patient he will go through maybe 3 recurrence or whatever. So we have to lead the eye to the end of the disease with the minimum damage and the maximum vision. And that's why I think that we should keep peeling until the eye is quiet. And then maybe if we are forced, we do the retinectomy as peripheral as possible. And then we save more retina pressure and vision. But yeah, they are so difficult that it's hard to make rules.
Exactly. I agree with you, Barbara. You're an experienced surgeon.
Okay. Probably not as much as all of you. Go ahead, Atul.
Okay. Thank you, sir. Our next is... Thank you, sir. Thank you, sir, for excellent talk. Our next speaker is Dr. Zofia Michalewska from Lodz, Poland, and she will talk on our journey through macular hole.
Ladies and gentlemen, Chairman, I'm happy to be here with you. Thank you, Atul, for inviting me, and thank you to all the attendees to be here with us in these difficult times. The original inverted ILM flap technique, first described by our group in 2010, consisted of peeling of the ILM from all sides of the fovea and putting it gently on the top of the macular hole, as you can see here in this video and animation. Since that time, I'm very happy that hundreds of researchers confirmed our data and introduced many interesting modifications. One of the modifications I used until today was confirmed by our group with a prospective comparative randomized study, and namely temporal inverted ILM flap technique was stated to be non-inferior to the original one. In this technique, we remove the ILM only from the temporal side of the fovea and again cover it very gently. In this manner, we obtain excellent anatomical and functional results while not destroying the retinal nerve fiber layer on the temporal side of the fovea. What we confirmed with a Schwetzer's OCT angiography study is that in the area of peeled ILM, Some defects of the deep vasculature of the retina are created, as you can see here on this image on the left-hand side, in the area of unpeaked ILM. In the temporal inverted ILM flap technique, we save a lot of vessels in the deep retina. An interesting aspect of the inverted ILM flap technique is a new closure type, namely the flap closure, which we observed in about 15% of cases. We analyzed this type of closure. Of course, it improves with time, but probably the eyes that close with the flap closure would remain flat open if they were treated with ILM peeling alone. A lot of people ask me whether some remnants of the ILM might proliferate into epiretinal membranes and influence visual acuity. And we confirmed in a study that they have no influence on final functional outcomes in such patients. The inverted ILM flap technique might be implemented in a lot of other indications besides idiopathic large macular holes. Several authors and our group confirmed its use in high myopia, as you can see here in this video. The appearance of macular holes in high myopia differs quite from that in idiopathic cases. They are often coexisting with fovea detachment. Similar appearance might be observed also in proliferative diabetic retinopathy, and also in these cases, the use of inverted ILM flap technique might improve anatomical and functional outcomes. In those cases, you must wait several months until the fovea is completely dry and attached, because these cases are much more severe than idiopathic ones, as you can see here in those Schwetzer's OCT images. Another rare indication might be a Coats disease. Only 1 or 2 cases of surgery in macular hole exist in this rare entity, and with peeling of the island from the temporal side, we might obtain excellent visual outcomes, even if we have to wait for the final visual acuity several months. We also confirmed the use of this technique in dry AMD. We analyzed 23 patients in which we improved the functional and anatomical results of macular holes coexisting with drusen. An interesting aspect of our study was the disappearance of drusen in several patients, probably due to phagocytosis of drusen after removal of the posterior hyaloid. In some rare cases, after 1 or 2 years after surgery, it might progress to choroidal neovascularization, or even the other way around. We operated on several cases of full-thickness macular holes appearing in the course of treatment of choroidal neovascularization in AMD. It is possible to close these macular holes, but those patients require anti-VEGF treatment continued for life. Repeated surgery is another interesting aspect. When performing the inverted or temporal inverted ILM flap technique, the failures are very rare, but still it's very easy to redo the surgery. And we stated that it is no difference if you use air or silicone oil in those eyes. If you perform during the first surgery complete ILM peeling, there are also several possibilities to cure the patient. You can do either an autologous transplantation of the ILM or a transplantation of the autologous lens capsule. Even if the lens capsule might seem a little bit more easy, patients usually have better visual acuities after autologous ILM transplantation. You can see here the course of events in Schwetzer's OCT and Schwetzer's OCT angiography. An interesting aspect is this hyperreflective space seen a few weeks after surgery at the level of the choriocapillaries. And it disappears after 2 years. Thank you for your attention.
Thank you, Dr. Zofia. And I'd like to ask one question. Today, if one patient has come to you with a 500 micron macular hole, which technique you will follow, the conventional or the temporal flap?
I always do the temporal flap. Now I use it for every patient. It saves the retinal nerve fiber layer at the nasal side of the fovea, and in case of failure, you still have some ILM to make another flap.
Okay. Dr. Ramsey, sir, your voice, you are on mute. Dr. Ramsey, you are on mute.
Microphone.
Okay, sorry. It's a great talk, Sophia. So my first question was Dr. Atul already asked you and you answered, but the second one is, do you believe that a single inverted flap
To stage 4, macular detachment with no schisis. In the columns, you see the evolution which runs tangential to the foveal plane from stage A, normal fovea, B. Lamellar macular hole. C. Full thickness macular hole. In some stages, you can also have the addition of an outer lamellar macular hole, which is a splitting in the photoreceptors layer. You will also find the average visual acuity and the mean time taken to evolve from one stage to the next as prognostic factors. You can try and classify different pictures. This is stage 1A+, with schisis in the inner layers, intact fovea and epiretinal proliferation. This is stage 3, combined schisis and detachment, and A because the fovea is intact. Again, stage 3A, schisis detachment, intact fovea, but with an outer lamellar hole, so stage 3AO. This is the most common 4C, detachment with macular hole. MTM evolves in the same eye with the time. This is an example of evolution perpendicular to the retina from schisis to detachment in over 9 years. And this is an example of evolution tangential to the fovea from an outer schisis with the lamellar macular hole to a 2C, full thickness macular hole in 1 year. A staging system must be practical. The MSS has the aim of offering information on nomenclature, prognosis, and finally treatment. But how to develop guidelines to treatment based on MSS? I have reviewed more than 300 cases operated by myself since 2007 with different techniques, then selected 157 that had reliable data and at least 2 years follow-up, and analyzed the anatomical and functional results. And the question was, what is the best treatment per each stage? This is in summary what I found. Stage 1A, 2A, 1 and 2B have good vision and progress slowly, so don't treat them, just observe. Think about treatment in stage B only when vision drops. If MTM evolves from schisis to detachment, but the fovea is in stage A, no splitting, then apply only a macular buckle, like in this example of stage 4A, treated with macular buckle to reattach the sclera to the retina. If MTM evolves in the fovea with a splitting, then apply only pars plana vitrectomy and maneuvers on the ILM, like in this example of stage 1C, treated with the vitrectomy and ILM peeling and flap. If you see a detachment but combined with a macular hole, then apply a combination of buckle plus vitrectomy to reattach the sclera to the retina and close the hole, like in this example, treated with a combination of techniques. So this is the MSS table with addition of the guidelines of treatment customized per each stage. I can show you how to make a buckle if you don't have one, like this, and how to insert the buckle in the superotemporal quadrant, checking the position of the buckle with a panoramic viewing system and the intraoperative OCT. I have been using the Zeiss, now I have the Leica and Focus. Very useful, not mandatory. The buckle is then sutured in the superotemporal quadrant in a well-exposed area. You see here an example of resolution of 3AO just with the buckle in 3 months. And here another example of 4C treated with buccal vitrectomy peeling. It was done at live surgery in flow retina, maneuvers on the hole and on the posterior cortex, and the resolution 1 month after surgery, flat retina closed hole. I have implanted a buckle just with the guide of intraoperative OCT without fiber optics or other means. More difficult but extremely interesting. In conclusion, I would like to invite you to validate the MSS and share with me your thoughts on treatment option. Email me to parolini@gmail.com. Thank you.
Thank you, Dr. Parolini.
Thanks.
Very nice talk.
Thank you.
Very difficult surgeries. Not easy for everyone. And Dr. MG?
So this is great. This is great talk, Barbara. So, in my practice, I really usually sometimes in some patients, if their patient has posterior staphyloma, it's really difficult to visualize ILM and to peel ILM in these long eyes. Do you have any trick during the peeling of ILM in such eyes and staining or visualization lens system? And what's your technique? Could you please mention about the details little?
Right. Extremely difficult, especially because of the lack of contrast. The choroid is atrophic. So what I usually do, first of all, in these cases, I use also a buckle, so the eye is shortened and I have less difficulty with the instrument length. And then I perform vitrectomy and exchanging air, trying to, if the detachment is not too large, I try to remove the fluid through the hole, but not touching the hole, just in front, because it is very dangerous and the risk of aspirating the edges of the retina is high. So I stay in front, and then under air, I stain with, I use the staining, and of course, most of the time it goes underneath. So after staining, I insert PFCL and I peel under PFCL and buckle, and that makes it just a little easier. Using the intraoperative OCT in these cases becomes extremely useful because sometimes you don't even see the hole. Instead, with intraoperative OCT, you have the confirmation of where the hole is and what you did with the flap. Of course, intraoperative OCT is a luxury now, and I'm still studying it, but I can tell you it's a very good friend. Anyhow, yeah, so I think that is the technique that is a little bit less difficult. And then I exchange, of course, I remove the PFCL, exchange in air and leave gas. The effort of leaving the macular buckle is also, first of all, to avoid the recurrence of detachment, and second, to avoid silicone oil, because I have seen that silicone oil in these eyes can very easily lead to glaucoma, and then you attach the retina and you lose the eye because of the silicone. So that's it.
Thank you, Barbara.
Thank you.
So usually at what vision you operate the patient? If the patient is coming to you at 612, 618, will you operate the patient or you will wait?
No, 612, I would still wait. And we are speaking about schisis because, of course, we are speaking about intact fovea. Usually when the schisis evolved into detachment, even if the fovea is not split in the hole, the patient lose vision. They go like in 2100, 2200. And so it's time to place just a buckle. And if there is a hole, a full thickness hole, then of course I treat the hole. If there is only schisis and 6/12, I wait.
Thank you.
Welcome.
Okay. And any other person, any other doctor want to ask?
Is that the table should be what I think I learned from my mistakes in so many years, and what I think could be a good compromise in the choice of treatment with these difficult eyes. That's why I wrote the table, because I know everybody is in trouble with these eyes, and so having a comparison could help us exchanging ideas on what to do per each stage.
Thank you very much. I think everybody will also follow the same.
Thank you.
Now I would like to ask Dr. Sunir Garg, please come. And the topic is diabetic retinal detachment for Dr. Sunir Garg.
Hi, can you? Thanks, Atul, for organizing a great conference. I've learned a lot from everybody so far. My talk will be a few pearls on proliferative diabetic retinopathy. Sorry, wrong thing. Okay. Sorry about that. I am a consultant for Bausch & Lomb, and I will talk a little bit briefly about their one of their products. So although our techniques for the repair of PDR have changed a lot, the goals remain the same. Those goals will be to remove the media opacity as well as to relieve the proliferative process. There's three pearls I'd like to touch on today. One is the role of PRP in anti-VEGF therapy prior to vitrectomy. The second are the benefits of small gauge vitrectomy. And third is to briefly touch on hypersonic vitrectomy, which is an interesting approach for this. One of the studies our group did a number of years ago looked at postoperative hemorrhage in these cases. And when we were doing 23 gauge vitrectomy, about a third of the patients had some postoperative hemorrhage after diabetic vitrectomy. And we found that the amount of postoperative hemorrhage related to what was then the amount of preoperative PRP, meaning if the patient had a lot of PRP prior to the vitrectomy, they had less of a hemorrhage post-op. If they had very scant or no preoperative PRP on board, they tended to have more post-op vitreous hemorrhage. So at a minimum, putting in PRP can be very helpful in these eyes. Since then, however, I think a lot of us have switched over to using anti-VEGF injections. We know from a number of studies that anti-VEGF injection prior to vitrectomy reduces both intraoperative as well as postoperative hemorrhage. You can inject it anytime within 2 weeks of the surgery. We tend to inject earlier if a patient has extensive membranes. If you look at these pictures, on the lower left, there's a person with very vascular, very active membranes that are surrounding the macula. If you look at an OCT in this individual, the fovea is on, but the perimacula is detached. If I'm going to inject these people, and I will, I'll tend to do that just a day or two before the surgery. In these type of eyes, I'm concerned about crunch. In contrast, if I look at the middle picture at the bottom, this person has fairly chronic, fairly old, fairly avascular membranes. I'm not worried about crunch in this eye, so I'll inject them a week or two before surgery, if at all. Next, second pearl, our surgery has improved a lot, and one of the main reasons we're getting better outcomes with these cases is because we're more and more using small gauge vitrectomy. There's a few advantages. Number one, you have better control of the IOP, largely because of the valve cannulas, and that reduces the amount of intraoperative hemorrhage and lets us control the hemorrhage a lot better if it does occur intraoperatively. The second big advantage is the smaller gauge vitrectomy instruments themselves act like scissors, which are great for dissection, and for a lot of us, I think it's easier to use than manual scissors. All of the small gauges work really well. For most of the cases, I'm using 25 gauge vitrectomy simply because the diameter of that instrument is quite small. 27 gauge, however, acts like a great scissors. As a rule of thumb, I don't like the 27 gauge platform. The fluidics are not very good, the instruments are quite slow, and I don't have a lighted laser, which for me is a really helpful instrument. So we'll do something called hybrid vitrectomy, and myself and one of my colleagues described this a few years ago. This person has a 27 gauge cannula. You'll see that there's a number of ports set up, and we'll do our standard vitrectomy using the 25 gauge cutter, and that's great for removing the vitreous hemorrhage as well as relieving AP traction. We have a chandelier in this eye, which enables us to do bimanual technique. In this case, we are using scissors to do membrane peel and dissection in these flat membranes. But once we remove that, we switch over to the 27 gauge cutter, and the very narrow diameter allows us to use this like a vertical scissors, and we can section and delaminate the membranes very well. In this instance, the reduced flow rate through this instrument can be helpful. I think gives you more control when you're trying to delaminate the membranes. The third thing I like to touch base on is hypersonic vitrectomy. The guillotine cutters are amazing, but as you'll see from the schematic, when they aspirate, there is a fair bit of traction on the retina, and particularly in these ischemic eyes, I'm worried about that. In contrast, hypersonic vitrectomy does not cut. It liquefies the vitreous gel, and you'll see that here. This allows for a more consistent removal of the vitreous gel. You'll see that the port is really small at the very distal end of the instrument, which may enable us to remove membranes from the surface of the retina in a more controlled manner. Now, one of the difficulties we've been having with the hypersonic vitrectomy is it works pretty well for the vitreous removal, but for the diabetic membranes, it can be a little bit hit or miss. If it's a finer membrane, small pegs, it works really well. And you can see the very distal small port enables us to, in a very controlled manner, remove the membranes. However, for very thick fibrovascular membranes, nothing works as well as a guillotine cutter. So in summary, preoperatively, anti-VEGF therapy, or if you don't have access to that, PRP preoperatively helps a lot. Smaller gauge vitrectomy, I think, is advantageous for these cases, and newer vitrectomy technologies are in development that might make these cases safer and even more fun to do. Thank you very much.
Thank you, Dr. Sunil, for a great talk. One question from my side. If a patient is coming to you with a very florid vessels over the disc and also on the arcade, at what time before the surgery you will inject the anti-VEGF? 2 days, 5 days, 7?
So if it's really active neovascularization along the disc that looks like it's connecting to an NVE along the arcades, and I'm worried about that active membrane contracting very quickly, I'll do the injection a day or two before the surgery. That works pretty well for me and I think limits any concern I have about crunch. The other thing that I make sure of is that all their preoperative paperwork, their EKG, their medical clearance, which in the US is a big deal, has all been accomplished before I inject them. We've had some cases where we inject them, the day before surgery, and then they show up to the surgery and then they're not cleared by anesthesia for the surgery. The surgery then gets postponed for a couple of weeks, and I've had some bad outcomes in that scenario. So once their preoperative paperwork is clear, I'll then inject it a day or two beforehand with the assumption that the surgery will happen.
Okay. The second question I want to ask, if very old TRD is present and the fluid is there over the posterior pole and there is no sign of combined RD, whether you will go for draining of the fluid or you will leave the fluid like this?
So there's chronic subretinal fluid from a long-standing traction retinal detachment?
Yes.
Yeah, so you've talked about this a fair bit, though, and for many of the cases, I will tend to leave it if I've relieved the pre-retinal traction with no breaks. Often that fluid will get absorbed, although slowly. I'm a little hesitant to make a deliberate break in these eyes, but you can do that. Alternatively, I think you've talked about doing external drainage in those cases, where much like you would for a buckle, you go outside the eye, make a scleral cut down, and drain the subretinal fluid that way, and that can be a good approach as well. But as if those techniques become more, sometimes I think you try to get too fancy, and that can cause you more trouble. So a lot of times I'll just leave it alone.
May I ask a question, Dr. Garg? So it's a great talk. In case with tractional retinal detachment, and after peeling all membranes, if there is no retinal tear, pre-existing tear, and also an iatrogenic tear, how you behave? Do you use tamponates in such patient or leave the eyes without tamponate material?
So if there's no breaks, I will routinely, in all cases, leave a total air fill because I think it reduces postoperative hypotony, and there's some data to suggest that it may reduce post-op endophthalmitis. I've also had some anecdotal experience that it may just reduce some of the early postoperative vitreous hemorrhage that we see. For those scenarios, I do it. I'm a little concerned in these eyes of leaving them only with fluid because I have seen hypotony on post-op day 1, and I think there can be a little bit higher incidence of postoperative vitreous hemorrhage with fluid alone.
Good.
Okay. Pramod sir, you want to ask something?
Yeah, no other question. Thank you very much.
Thank you, Dr. Sunil.
Thank you.
And
Is there time for the last question?
Yeah.
For chronic subretinal fluid in vitrectomized eyes, do you think it would make sense to try and just inject some air or gas and just mechanically push with face down, or it does not make any difference?
And I look forward to hearing your experience. In my experience, it doesn't seem to do very much. I think, at that point, the fluid presumably is very chronic and thick, and I have not seen it consistently keep the fluid away from the macula. It may help transiently, but until the RPE pumps it away, I don't think it's going to permanently flatten your macula in a meaningful manner. Do you have a different experience?
Well, but it's only case report, so it doesn't make a rule. I just found in a 2 or 3 patients I did not collect the data that I could inject, and thin the amount of subretinal fluid. So then by doing a micropulse laser, I could reabsorb the fluid much quicker. And that just helps in regaining better vision instead of leaving the subretinal fluid. But, it's only few cases, it doesn't make any rules.
Sure.
Thanks.
Thank you, Dr. Sunil.
Thank you.
Our next speaker is Dr. Pramod Bhinde sir, and he's from Shankar Netralaya, and he is going to talk about the vitrectomy for stage 4 ROP.
Sorry. Okay, so thank you very much, Dr. Atul and Dr. Ashish, to having me here. Wonderful meeting, actually. And I think I'm going to close the session here with after this talk. So, well, we'll start with the stage 4 retinopathy. Basically, we define stage 4 ROP is partial retinal detachment. If you have stage 4A, where you have extramacular detachment, and if macula involved, you classify as 4B. Well, depending on a configuration of detachment, you decide your surgical option. Either scleral buckling, still have options, we'll come to that a little bit later on, or vitrectomy, either standalone or can combine with lensectomy and occasionally with scleral buckling as well. So coming to scleral buckling per se, this is a typical case having a nasal retina nicely attached. There's not much traction on a posterior retina except peripheral traction, what probably detached part here. And then what I did is decided to go buckle both the eyes, segmental buckle, as you see the schematic drawing here. This was another eye where traction was much more extensive along the periphery, so decided to support with the encircling band. So you choose the encircling band or segmental buckle depending on the traction, extent of the traction. And obviously the aim is to support the traction, and most of these eyes you cannot drain subretinal fluid, so probably you have to do repeated anti-chamber tap to achieve your buccal height. You have to be careful because retina is extremely thin, muscles are thin, very easy to snap those, and also angle closer glaucoma in early post-operative period. You need to watch these babies for vital signs because post-GA apneic spells. Coming to lens sparing vitrectomy, sclerotomy, as Dr. Sengul already mentioned, along the parallel to the visual axis, anterior place sclerotomy somewhere around 0.75 to 1 millimeter from the limbus. Usually these are step incision generally not possible because sclera is extremely thin, and preferable to have a wide angle visualization system during your surgery. The traction forces you generally, obviously you would like to address. This is like showing the same anteroposterior traction. You have to see the retrolental membrane stalk you are removed, and then continue down forward doing your anteromid vitrectomy along with removing the stalk that takes care of your anteroposterior traction. And then subsequently, what you need to go ahead with a trans-reach traction, what you see here, and also traction which extending from disc to the reach. Meticulously, all these membranes you need to remove. Take care that each layer lifted up, removed. Of course, PVD induction will not be possible, so you are going to trim as much as possible. And once that is done, also what you look at it, taking care of reach to the aura or ciliary body area, those membranes, you trim it. Now, when you're approaching this area, generally what you have is extreme periphery, and particularly when you are planning to save the lens, you need to change your hands, go on opposite sclerotomy to approach these areas. Occasionally, you need to use a cautery. If there are bleeders, elevated bleeders, you can use for that. Well, like a diabetes with advanced web of instrumentation, and particularly you have multifunction instrument. As you see, occasionally you can use bimanual technique to usually can very easily remove these complicated fracture detachments to handle, and things become much easier to handle. Now you have much better control on intraocular pressure using bimanual technique. Now, so few cases you have a peripheral traction and you have a posterior traction, and in those situations, obviously, as I said, complete traction delivery removal is not possible. So either you can combine it with a lensectomy or without lensectomy. But when you have something like case here, extreme peripheral traction, and though you can cut most of the traction using bimanual technique, but you have a part of membrane, as you see here, is still stuck at a, you cannot remove this. So this part I decided to support with the buccal encirclage. As you see, the membrane was quite extensive, and all along with vitrectomy. So this is a typical example when you combine all three techniques: visualizectomy, use buccal, and also vitrectomy. Here just showing supporting with the encerclage to achieve your desired outcome. So to conclude, in stage 4 ROP configuration, the detachment can be variable, obviously, and depending on configuration, you decide your surgical option. Lens-sparing vitrectomy forms a main surgical intervention strategy, although lensectomy can be needed in few cases, particularly when you have anteriorly grown membrane. Scleral buckling still has role in a select group of eyes, and with MIVS and multifunction instrument, offering better and safer approach to peripheral retina, allowing more and more complicated surgeries to be performed with improved anatomical and functional outcome. And even occasionally, you can avoid using cannulas, direct sclerotomy, what we conventionally used to do 20 gauge sclerotomy, but using 25 or 23 without having cannula to anterior approach can be much easier. So thank you very much for patient hearing. Natul, once again, congratulations, wonderful meeting. And I think just trying to so many talks and juggling a time to still keep timing, I think really great achievement.
Thank you, sir. It's all because of you people who have accepted the invitation. Thank you, sir. Dr. Sunir, you want to ask any question?
With these, have you found some people have talked about using specialized vitrectomy instruments that are shorter than the standard probe for these eyes? Have you found that to be helpful?
Yeah, that's right. We use smaller length instruments. They are available now. So things become the advantage because they are smaller, so they are stiffer. So maneuverability is much easier. Now, Alcon infusion cannula, the issue is we have to suture it. As against you have a dark system, you can manage it without suturing. But then because the cannula being 2.5 millimeter, chances of slippage are high, so we have to be extremely careful while working with those systems. So otherwise, yes, stiffness definitely helps you to maneuver, particularly when you have peripheral traction, you have extensive membrane dissection, it's much easier that way.
Dr. Parolini?
No questions, no experience.
Okay, Dr. Ramsey?
It's great talk, but I have no experience and no question at all.
Thank you, sir. Thanks.
Thank you, Atul.
I think it's time to wind up the session and wind up the conference. Thanks to all of you, all the stalwarts who have accepted our invitation and grace us with their presence. Thank you all, and hopefully next year we will come with the offline conference. Hopefully this COVID era will over and we'll meet in person. Thanks to all of you.
Thank
Good.
you.
Thank you very much.
Have a good day.
Good night.
Thank you. Bye bye.
Good night.
Thanks
Okay,
at all.
bye. Good night, sir.
But great meeting.
Great meeting.
We really enjoy. Really enjoy.
Thank you, sir.
Bye bye.
Thank you, Goral sir.
Thank you.
Thank you for a great talk, sir.
Great talk from everybody.
Yeah. Thank you, Sinu sir.
Thank you so much, everyone. It was such a pleasure.
Thank you for accepting our invitation, sir.
Of course, never think otherwise.
Okay.